intraoperative inlay. So we have to discuss what about lab IPOM, the intraperitoneal only mesh position. Is this quite good, and are the results as good as we know from sublay? So this is the paper from Hahn, 2007, looking at intraperitoneal hernia repair and subsequent abdominal surgery. And the comparison between IPOM and preperitoneal mesh is like that. The post-operative complication rate is significantly higher after IPOM. Small bowel resection in some cases has to be done, as well as the surgical site infection rate is higher, and enterocutaneous fistulation is one of the most severe complications you can have after IPOM. So what about the combination of minimal invasive surgery and preperitoneal mesh placement? The advantage of minimal access, like the IPOM, can be combined with the classical sublay mesh position, and you have less wound complications and pain. The safe mesh position is guaranteed, and the integration, adhesions, and long-term complications of IPOM mesh could be prevented. Use of flat macroporous mesh without coating may be another advantage and much cheaper. So the principle of the best mesh placement is, of course, the sublay based on Reeve-Stauber work. So new techniques of extraperitoneal mesh placements starts at 2002 by Mark Miseres. He did the first endoscopic total preperitoneal ventral hernia repair, and it took a long time. Then there was Wolfgang Reinpold, 2012, starting with a mini or less open sublay operation, a so-called Milos technique. And together with Reinhard Bittner, they had the idea to do it endoscopically as well. So it was created E-Milos. And afterwards, 2012, we had, starting at the idea from Jorge Daez, the enhanced new totally extraperitoneal technique for repair of inguinal hernia, a new approach, was done by Igor Belyansky and Victor Radu to use this approach for a laparoscopic retromuscular hernia repair. Of course, we had at that time already some reports from robotical assisted repair of the whole wall, and Conrad Bellesi is one of the mentor of this technique, and he has also focused on the so-called robotic transabdominal preperitoneal approach for repair of primary uncomplicated ventral hernias. So this is quite also the focus of robotic assisted surgery. So coming now to the guidelines for treatment of umbilical and epigastric hernias from the European Hernia Society and America's Hernia Society, published 2020 in British Journal of Surgery. Out of the literature, 114 studies were included, and we'll just focus on the main key questions. Is there a place for suture repair in elective umbilical or epigastric hernia? There is the recommendation that you should use a mesh, and only in small defects less than 1 centimeter you can have a suture repair. The quality of high evidence is high and strength of recommendation is strong. Coming to the question, which is the preferred technique for suture repair? Recommendation is to use a slowly resorbable or non-absorbable suture, and the suture technique can be chosen by the surgeon. You shouldn't use any kind of quickly absorbable sutures. Quality of evidence is low and strength of recommendation is weak. So now coming to the question, optimal surgical approach for acutely strangulated or incarcerated umbilical or epigastric hernia. Of course, there are many patient-related factors which play a role, and of course, different morbidity and mortality as well has to be considered. Low-level evidence regarding non-resorbable mesh to be safe for strangulated incarcerated umbilical epigastric hernia repair, but you can mesh use anyhow in clean contaminated surgical fields. So the recommendation is, of course, in emergency repair of umbilical or epigastric hernias should be tailored to the patient and hernia characteristics, but you can use a mesh if you are safe. So quality of evidence is low and strength for recommendation is weak. Coming to the next question, which is the preferred type of mesh and preferred layer? So we know that intraperitoneal preformed patches may shorten operating time, but are associated with increased complication rates. We have, on the other hand, a placement of mesh in retromuscular prepeitoneal position without any complications and especially lower rates of surgical site infection and recurrences. And therefore, the recommendation is to use a flat permanent mesh in the prepeitoneal space for open umbilical or epigastric hernia repair. Quality of evidence is low. Again, strength of recommendation is weak. So coming to the mesh overlap, again, we have not really enough evidence for the specific mesh overlap for any recommendation, but we know that the overlap of 3 centimeters as associated with low risk recurrence rates in defects up to 4 centimeters. Therefore, the recommendation is to have this overlap in defects up to 4 centimeters in the prepeitoneal mesh repair. Quality of evidence, low, strength of recommendation weak. So coming to the suggested algorithm of the guideline groups, and you see the defect size up to 1 centimeter. You have an open approach with mesh, a preperitoneal flat mesh with 2 centimeter overlap. Up to 1 centimeter, you can use also a suture repair, non-absorbable or slowly absorbable suture. 1 to 4 centimeters open with mesh should be a preperitoneal flat mesh with 3 centimeter overlap. Laparoscopic procedure should be done preperitoneal or retromuscular mesh placement with 5 centimeter overlap. And all other defect size more than 4 centimeters should be treated like an incisional hernia. So what about guidelines in the real world of surgery? So looking at the hernia med data from the Hernia Med registry published recently in Hernia by Fred and Köckerling, looking at the treatment of small umbilical hernias less than 2 centimeters and guidelines and current retrends from the Hernia Med registry. Looking at the techniques used in these small defect umbilical hernias, you see predominantly a suture repair. This is the blue line. And the other seen open IPOM, lap IPOM, and others. And if I look at the situation regarding the others, this is the group which is new, the green line. Then there's a significant increase from 2013 to 19, the p-value is significant. You see 6.5 rising up to 9.4, what means that there are the new techniques, the preperitoneal mesh repairs, also sublate pump technique and Milos procedures. And these are new, of course. Complication-related reoperations. You see they're all listed, all the lines for the different procedures, and you see there is only there's no significant differences seen between the different procedures. Pain requiring treatment at 1 year follow-up. You see there are different curves, and the highest pain rates are seen in the open onlay followed by the lap IPOM, and also for open IPOM, the other are lower than 2%. You see there's no significant differences seen in comparison of the different techniques. Recurrence rates, it's 1 year follow-up. You see there is 2% for suture technique, and the others are very close together. But you see an increase for the open IPARM from 2017 to 2018, rising up, as well as the others seen quite without any significant differences in comparison together. So this is the open IPARM group, which might be a problem. So coming to the summary, the treatment of small umbilical hernias in the HerniaMed registry, contrary to the guidelines recommendation, the findings of meta-analysis, the proportion of suture repair in this analysis has remained stable over the past 10 years and lies in about 75%. There is an increase of other techniques, pre-pedal mesh repairs, as well as sublay, Milos, E-Milos, and you see also highest chronic pain after open only, lap and open IPARM. High complication-related reoperation were seen in open only and open IPARM. High recurrence rate after suture repair in about 2%. So coming to the next paper, which is recently published, also from the same group, HerniaMed registry, looking at the epigastric hernia repair. And you see the technique used for this repair. And the first line, it was done in an open suture technique. You see 32%. This is again the overview from starting 2010 to 2019, and the p-values comparison between 2013 and 19. So looking at that point, you see a crossover of the lines of the yellow line. This is the open sublay, which rises up to be the second frequent operation technique, and coming down a decrease of the lap IPARM. So, and new techniques, this is the red line, the so-called other procedures, including rising up. So if we look at the p-value between 2013 and 19, the three groups significant different. Other procedures, this of course is again the two techniques, the pre-pedal flat mesh technique, E-Milos, and ETP. So coming now to the complication-related or reoperation rate, you see this was not significant. There was just one peak in open only, but you see very close together. The highest reoperation rate we're seen after open sublay. This was 1.9. So coming now to the 1 year follow-up chronic pain required treatment. You see there was no significant differences seen. Open only had the highest percentage, and lap IPARM as well, more than 4%. So recurrence rates after 1 year follow-up was no significant differences. And the first line, the yellow line, you see there's a peak from 2017 to 2018, rising up, but the other one still are very low, below 4%. So coming to the summary, regarding treatment epigastric hernia repair, there's a decrease of laparoscopic IPARM and epigastric hernia repair in the HerniaMed registry, as well as an increase of open sublay operation and other techniques. And there is a reduction in the postoperative surgical complication rates from 3.8 to 1.9, whereas no change in complication-related reoperation rates and no impact of new techniques on outcome at 1 year follow-up. High chronic pain after lap IPARM and high recurrence rates and chronic pain were seen after open-only technique. So coming to my take-home, avoid elective surgery on recurrent smokers and in patients with BMI more than 50. Sutured repair should be only done in small umbilical and epigastric hernia defects of less than 1 centimeter. Use a flat permanent mesh in pre-pedal space for open umbilical or epigastric hernia repair. And look into the HerniaMed registry, umbilical hernia open, only, open, and lap IPARM are followed by a higher recurrence rate, a higher chronic pain rate, and a complication-related reoperation rate. And epigastric hernia have a high recurrence rate as well as chronic pain after open-only technique. There's an increase of open sublay and other techniques like the Mylos, E-Mylos, ETP, and preparatory flat mesh technique without association of high complication rates or reoperation or recurrence rates. So thank you for your attention. I would like to invite you to join our meeting in December 2021 in lovely Salzburg city in Austria. Hopefully it will be a physical meeting, a face-to-face meeting. Thank you for your attention.
Go ahead.
Thank you, René, for this very nice overview as a starting for today. Now we're going to South Africa. We have Heather Bogart on the program from the New Somerset Hospital. She's there, the head of surgery, and she will talk about, René?
Lab IPOM is still a compelling choice. We are very curious about this lecture.
Let's go.
Greetings, friends and colleagues around the world. It's a real privilege to be with you today. I'm bringing you greetings from Cape Town, South Africa, and I'm going to discuss with you a little bit about lap IPOM repair, and I hope to leave you with the thought that it's a really functional and facile favorite operation. Like with all revolutions, the revolution in minimal invasive surgery for ventral hernias started with great expectation, enthusiasm, and rapidly followed by a lot of disillusionment, mainly because of pain, pseudo-recurrence, the problems with enterotomies, the difficulty with tackling large defects, and the possibility of mesh complications. And so our quest for the perfect reconstruction continues, and we're trying to improve upon the legacy left for us from LeBlanc and Booth, who first published the idea of this procedure in 1993. Really what we're trying to do is balance the morbidity that we have from extensive dissection, like we have in open hernia surgery, with the morbidity that is generated from manipulating the mesh and the visceral structures intraperitoneally. Nowadays, we have a plethora of options available to us, and if you can think of any acronym, it probably describes the possibility of a ventral hernia operation. And like whenever there are many possibilities, you really need to think, is there an ideal, and realize that there probably isn't one, and we should be tailoring our selection of the operation according to the surgeon, the patient, and the circumstances we find ourselves in. So I'm going to start with just a little bit of a comparison between laparoscopy and open approaches so that we can get a general sense of why laparoscopy, or in which scenario laparoscopy is better. So just looking at the things for which there's level 1 data, the most important being significantly less surgical site infections in lap IPOM. Also, health-related quality of life is significantly better. And if we look at the subgroups of patients, obese patients have less complications, lower morbidity, lower mortality. In emergency scenarios, we have pretty compelling data, and also in patients who have chronic lung disease. There are a number of things for which there are no differences, and that would be operative time, pain, recurrence rates, overall quality of life, reoperation rates, mesh complications. What about the disadvantages of the laparoscopic approach? We certainly know that in the incisional subgroup of patients, there are more serious complications. There's also a higher operative cost, and there's this looming possibility of missed bowel injuries. Just speaking about enterotomies, I want to bring this paper to your attention. So this is from 2015 Surgical Endoscopy, and it's a meta-analysis. And what we can see is that, in fact, the enterotomy rate is similar between open surgery and laparoscopy, but unrecognized enterotomies are, in fact, higher in the laparoscopic subgroup. What is important is that despite this, there's no disadvantage of the laparoscopic repair for unrecognized enterotomies. So, of course, we do know that the mortality rate is 400% for an unrecognized enterotomy versus a recognized enterotomy, but there's no disadvantage with the laparoscopic approach. So, with regards to adhesions and fistulas and the intraperitoneal mesh, this paper from 2016, Surgical Endoscopy, just looking at our registry data, we know that there really aren't any short-term or medium-term complications related to the mesh after a laparoscopic approach. We know the adhesion score is higher, but it doesn't carry any clinical significance. If we look at data from the Danish hernia database after 5 years of follow-up, in fact, what we do know is that mesh-related complications are 5.6% in open surgery and only 3.7% after lap approach. So in fact, there isn't any inferiority of an intraperitoneal mesh position. Fistulae, of course, are not a major sequelae of the laparoscopic approach, and we know this from cohort studies. This table comes from a really great paper published by Tim Tollens and our friends from Belgium in 2019 in Hernia. And it's just a comparison of the available comparative studies between various techniques and lap IPOM. So we have lap tap, the open retrorectus procedure, the E-tip, the E-melos. And I'm just going to draw your attention to the things that are significantly different. So first of all, with regards to recurrence, the E-melos is the only one which shows a superior recurrence rate compared with lap IPOM. All of the others are, there's no significant difference. With regards to seroma formation, again, the E-melos performs very well. We can see there from Kirkling's study, the open sublay repair. In fact, the seroma rate significantly higher in open surgery. No differences in length of stay. And when it comes to operative time, the two culprits here to note, the E-tip, which has got a double operative time compared with lap IPOM, and the lap tap, which also has a significantly longer operative time. Let's have a little bit more of a look in detail at what some of these publications show. So open retrorectus versus lap IPOM. So this is a study from Surgical Endoscopy 2019. It's actually not a study, but the hernia registry from Germany, almost 10,000 patients. And what we can see is that the complication rate is in fact threefold higher in open surgery. The reoperation rate also threefold higher for open surgery versus lap IPOM. And then if we look at intraoperative complications, the lap IPOM carries 2.3% risk versus the 1.3% risk for open retrorectus surgery. And there's no significant difference in recurrence and pain. So that's the big one, the open retrorectus, which many people consider to be the gold standard. What about the lap tap versus the lap IPOM? Well, this is from 2011 and is actually pooled data from both incisional and primary hernia cases. No significant difference really between these two techniques. The minor complications, recurrence, hospital stay, all the same. Obviously a shorter operative time that we've discussed with regards to lap IPOM and lower mesh costs with lap tap. But unfortunately, those lower mesh costs are offset by the increase in operative time. There's also a discussion about less seroma rate with tap, but this is a comparison with lap IPOM before the era of IPOM plus or defect closure. What about the new kid on the block, everybody's new favorite, the E-tip? Well, this paper from 2020, Surgical Endoscopy, is a comparative prospective study. And we've already discussed that the operative time is significantly higher for E-tip. Of course, post-operative pain, analgesic requirements, and the post-operative stay were significantly less. But unfortunately, the E-tip arm had 2 recurrences where there were none in the lap IPOM group. There are another 2 really great papers, one in 2021 from Hernia and one in 2019 from Surgical Endoscopy. And these 2 have comparable recurrence and complication rates between E-tip and lap IPOM. So if I have to summarize the differences between E-tip and lap IPOM, first of all, we have a significant mesh cost saving. And of course, we don't need to fixate the mesh, or if we do fixate it, we can fixate it with glue or something that doesn't require transfascial sutures or tacks. Unfortunately, it takes very long. It's at least double or approximately 3 hours of operative time. There's also extensive mobilization, division of the entire linea alba, and the potential to damage those important neurovascular structures in the linea semilinaris. In addition, it's quite technically challenging. It's really a fun operation to perform, but it's not for broad uptake. So what about if we have the robot to help us? Well, let's look at this paper from Nadia Henrichsen, published 2019 in Hernia. And this was a systematic review of the robotic approach versus lap IPOM. Comparable results with regards to recurrence and complication rates. With the robot, longer operating time, more seromas, of course, higher costs come without saying. So I think if we're going to consider the robot, it's really an additional tool. I think it has a really important role to play when it comes to complex ventral hernia cases, but it doesn't necessarily outperform straight sticks when it comes to the usual case that we'll be faced with. So if I have to summarize what I know from the data that's out there, first of all, the role for the laparoscopic approach versus open approach. So I would use this for all diabetics and other patients in my care who have immune risks, for all obese patients, patients with chronic lung disease, and I like to use this for strangulated incarcerated hernias or hernias that present as emergencies. What about with regards to the specific indications for the lap IPOM? Well, I use this for recurrent hernias after open surgery. I like this particularly for an undisturbed abdominal wall where you have multiple Swiss cheese defects and you essentially have a highly functional abdominal wall. It's also really great when the fascial defect is small, but you've had a long incision and you want to cover the entire incision length without disrupting what is intact. And of course, for lateral defects where you can't go, for example, in an ETEP plane. Just a quick word on the new improved lap IPOM Plus, which you all know really refers to the reconstruction of the midline or the eradication of the defect or the closure of the defect. So this is a really easy procedure to perform. The learning curve is only 50 cases, and it's quite quick in comparison with other techniques. There have been a number of mesh innovations and improvements, especially with regards to the visceral barrier, and it makes complications exceedingly rare. We also these days have better optics, we avoid energy, and we are very aware of the possibility of enterotomies and are therefore able to avoid them. So if we're going to choose this technique, we want to just bear in mind a couple of important technical aspects. First of all, we really want to avoid overfixation, which results in pain, and need to keep our mesh to tack ratio to 4:1, 4 centimeters squared of mesh to 1 tack. Defect closure really is a must, especially for defects that tend to be larger. I wanted to say this is defect closure or midline approximation, and many of you have quite sharply noticed that I haven't discussed LIRA, and the only reason why I haven't discussed LIRA today is because I don't have any comparative data for you. However, it is essentially mesh, which is in an intraperitoneal position, but with a very robust tension-free reconstruction of the midline, which does result in less pain. We also need to think of an adequate mesh to defect ratio with a wide overlap. And of course, we need to select our cases appropriately. So when it comes to concluding, and we have to ask ourselves the question, did the ETEP kill the IPOM? I think I'm going to say that the IPOM is a really robust method of repair. You don't need any special equipment. You don't need any advanced skills. And at the moment, I don't really have any compelling data or any study that's been shown to be any superior. So my conclusion is that we need to continue the quest. And I'll leave you with this quote from Vince Lombardi, which is that perfection is not attainable, but if we chase perfection, we can catch excellence. Thanks very much for being with us today. It's been a real pleasure.
America to Greece, and we're having Dr. Satakias with us, who is the general surgeon of the Inter-Balkan Medical Center in Thessaloniki, Greece. Benny, what will he talk about?
Minimal IPOM repair for incisional hernias out of the comfort zone. Please.
Dear colleagues, dear people from Bad, I thank you for the honorable invitation to be part of the International Hernia Symposium of 2021 in a time that our Earth is being conquered by this coronavirus. We're going to talk about incisional hernias and out of our comfort zone hernia repairs. There are a lot of repairs being performed every year in the likes of 100,000 repairs in the USA, half of them in Germany. Unfortunately, we don't have specific data to publish from Greece, and the indications for this repair have been already published. Is the pain, the aesthetics, burst abdomen, hood dehiscence, incarceration, maybe bowel obstruction, and the aim is not just to repair the anatomic defect, but also to render back the functions of the abdominal wall. What would be an ideal repair? That would be a low incidence of postoperative complications technique, one that has low recurrence rates, low incidence of postoperative pain, and the absence of a foreign body feeling in these times that the debate against meshes is very, very strong. And there are a lot of paths to follow with the open procedures, laparoscopic procedures, mesh techniques, suture techniques. It's which one to pick. In a recent paper published by Professor Kekeling and his team, it seems like the laparoscopic IPOM technique and the open sublay technique are the most commonly used. While in the Danish ventral hernia database, it had been shown that there's no really evidence comparing these two techniques, but they have less mesh-related complications with the laparoscopic techniques. So we see that the most common techniques is the open sublay, the laparoscopic IPOM, and the open IPOM. The others were rarely performed. They also published that there is a significant decline in the application of laparoscopic IPOM, and there are new techniques that are gaining ground, putting the mesh in the extraperitoneal space, like the E-Mills technique, the E-TEP technique. And of course, there are less open IPOM repairs being performed every year. So in the 2016 consensus for the ventral hernia management, a strong recommendation is to have a mesh repair for defects larger than 2 centimeters. And a weaker recommendation for synthetic mesh, the same goes for biological meshes. The mesh placement, the site of mesh placement is, sublay technique is preferred to be the most preferable, but with a weak recommendation. And approximation of the rectus midline is also suggested. In another paper, we see that wound complications, massive infections, and recurrences are very similar for the sublay and the open IPOM technique, while bridging techniques are worse, and laparoscopic IPOM technique is slightly worse as well. And in the recurrence per year, we see similar results from the sublay and the open IPOM techniques. So what does it really matter where you put the mesh? Yes, it does, because it can define the recurrence mechanism and also the possible complications in the future. And this is due to the very complex abdominal wall biomechanics. Since we have to deal with muscles and fascias and tendons, these are different materials from a synthetic mesh that we insert in the abdominal wall. And all the different powers and strengths that are applied against the mesh, all these forces are applied in the fixation points, and these are very weak, and all the tearing is witnessed at the fixation sutures. On top of that, the place of the mesh defines different complications. When we have an IPOM mesh, that means that we're exposed to abdominal viscera, and that means that the patient has adhesions, they can have bowel obstructions, they can have fistula formation. When the mesh is placed in the only fashion, then the patient has higher wound infection rates. And it seems like the sublay technique produces better results as far as recurrences are concerned. With the IPOM technique, as performed nowadays, we have to put the mesh in the intraperitoneal space, and then the suggestion is closing the rectus sheath in the midline, reapproximating the rectus muscles. But why do we have recurrences? It's because the meshes are not very well incorporated in the abdominal wall, And another problem is the fixation of the mass that can have hazards there, and the spaces that can form between the abdominal wall and the mass, and that can lead to hernia formation. So we know now the exact mass site complications that we have for the intra-abdominal masses and the onlay with large seromas or hematomas, and that the sublay is believed to be better. Also, when you put the mass inside the abdominal wall, then we have to prevent the erosion of the viscera from the masses. That is why those meshes, they have a double layer, they have an anti-adherent fascia towards the abdominal cavity. It was used to be EPTFE in the past, now it's Seprafilm and Sepra technology. But nevertheless, we still have, and we know from the papers that have been published, a lot of complications in the long time and many years after the operations. Suture techniques have more recurrences, but are safer compared with the complications produced by the mass inside the abdominal cavity. That's why we now use thermoabsorbable masses or biologic masses or long-term biosynthetic masses, but still they haven't been so well examined. The mass we use is the P4HB or Phasix mass for the IPOM technique. It had good results, some very promising results in the preliminary papers that have been published. It consists of a monomer of P4 hydroxybutyrate acid, which is very common inside the human body. But the most important feature is the fact that it has a delayed and predictable hydrolysis between 12 and 18 months. And when we use the Phasix ST, then we know that we have a separate technology layer for the phase that faces the viscera. And why use this Phasix mass? Because it is capable of producing a really strong fibrotic tissue. It's shown from the porcine models that have been examined before the preclinical studies, and it's also capable of inducing the M2 macrophage response, which leads to less inflammation, a better fibrotic tissue, which leads to better repairs. Now, what we normally do in our practice, in our hospital, is that we perform laparoscopic IPOM repairs for small defects. That means smaller than 6 centimeters. And we save open lap IPOM techniques for larger defects. We can perform a TAR technique with component separation when we have really contaminated cases. But these are rare. These are rare repairs in our private in our practice. So what means that we go out of our comfort zone? It means that we have to deal with a clean and contaminated wound, with an infected wound, an infected mass placed in the past. When we perform serious abdominal surgery, bowel anastomosis, and when we have a lot of comorbidities for this patient, but also when we have female patients in the reproductive age that they're willing to get pregnant in the future. The presentation of the case we're going to do today is a simple incisional hernia. That means we have no contamination, no infected wound, no infected mass placed before, but simply a 37-year-old woman with a high BMI, but she had a giant ovarian cyst removed through a midline incision, and 2 years after that repair, she presented with an incisional hernia of approximately 10 centimeters. So now the question is, which technique to apply to repair this hernia? When we have a large defect, we prefer the open repair. And in the question, which mass should be placed, we have to deal with a woman that is willing to get pregnant. So we believe that Phasix mass for this type of repair is suggested, and it's better to place there because it will not be there in 2 years' time. So it will not put any problems during the pregnancy. This woman has been operated in November 2019. She presented to us. She had this incisional hernia. Then we go through a midline incision over the previous incision of 15 centimeters. The sac is dissected towards the borders of the abdominal wall. we don't do any excessive dissection of the subcutaneous tissue because we want to prevent her from future seromas. When the whole sac was dissected, it was removed, and the defect is almost 12 centimeters, as you can see in the image. So then we decide to put a 25 by 30 phasics mesh, so to have a safe overlapping of at least 5 centimeters. This is the mesh, and then we have to cut off the lower side of the mesh so as to have the shape of the pelvis. Then, as it is inserted, the lower part first towards the pelvis, and we have to secure that with the capture tackers in direct side, as you see here, how in this graphic, how we can tuck the mesh over the pubic symphysis with direct side with a capture device. The stitches at the perimeter of the mesh are already placed, and then it is introduced inside the bowel, inside the abdominal cavity. And then we have to take out the stitches with a suture pusher. So we do an incision far away, we insert the suture pusher, we grab the stitches and take them out. Like you see here, I just have to accelerate the video a while. So the sutures are pulled towards the perimeter of the mesh. Then we have to do that for all the perimeter of the mesh, and this is how it looks. And then the midline incision is sutured because the phasics mesh certainly is not produced for bridging. When we close the midline, the mesh is secured in place, and then we stitch the PDS 0 stitches in the perimeter. We pull them out and we stitch them, and we put a drain in the subcutaneous tissue with a negative pressure. So this patient has been discharged 2 days after surgery, and the drain was removed 4 days after surgery. No complications in the first post-operative days, none till now. And taking into consideration that the mesh will not be there between 12 and 18 months, she was advised to start trying to get pregnant after the 9th post-operative month. So this is the technique that we use for difficult cases when we're out of a comfort zone, when we deal with contaminated and infected and serious operations. This is 10% of our hernia practice. Of course, pregnancy is a fact that we have to consider, is another factor that we have to consider a lot. We believe that this is a minimal open technique, which is easily reproduced. Well, we save it for defects larger than 10 centimeters. The phasics mesh is very easy to handle. It's also bioabsorbable. That means that we can apply the IPOM technique without being worried about future mesh complications. And do we believe that this is rediscovering the wheel? Certainly not, but I believe that it shows us the path to the future. And speaking of future, we hope that this pandemic will subside soon, and we see pictures like that for the humanity really, really soon. Thank you for your attention, and thanks again for the honorable invitation.
Thank you, Dr. Zacharias, for sharing this very interesting case. We're moving on now to Spain. We have Federico de Castilla-Diez as the next speaker. He is general surgeon in Quirón La Luz Hospital in Madrid, Spain. Benny, what is he talking about?
He will talk about endoscopic navigation of the anterior and lateral abdominal wall for totally extraperitoneal hernia surgery. We're very curious. So let's start with the lecture. Let's go.
Hi, everyone. My name is Federico del Castillo. I'm a surgeon from Spain, and I would like to thank to the IHS organization the invitation to talk about our endoscopic navigation experience of anterior and lateral abdominal wall for totally extraperitoneal hernia surgery. I would like to say that in our experience from the first cases in 1993 until these days, the evolution of minimally invasive surgery maybe has not been as quick and smart as we thought in the beginning. And as you can read in this paper, surgeons today, just 50% of surgeons are going minimally invasive in this kind of surgery. The evolution of the techniques has been really in a really not constant way from the external layers of the abdominal wall until the intra-abdominal approaches from the beginning to these days. As you know, we started with the IPOM technique in 1993, and that had an evolution to IPOM Plus with the fascial closure that reported lower incidence of adverse hernia-related events, and of course the transabdominal peritoneal approach that is having a new role today with new robotic approaches like TERAP, described by Musoms. And of course, I would like to say that we have a key point with the LIRA approach, the LIRA technique that was described by the Sevilla group, Morales Conde group, that treated not only the hernia, but the diastasis recti, but using an IPOM mesh, as you know, and with a highly technical, skillful technique. So from 2016, our group was analyzing that despite the multitude of methods, all of these new techniques that were growing was all these new techniques were going in the same way, and we thought that we should change that principles, and we start thinking about that the surgery of the abdominal wall, this minimal invasive surgery, was not only to put meshes into holes, but to find a reconstruction, an abdominal morphological reconstruction that was looking for a functional recovery. The mesh role was to reinforce our reconstruction. So we promote the mesh augmentation, and of course via minimally invasive access, trying to go always extraperitoneal if possible, and with the use of non-traumatic fixation methods that put us in a direction of looking for every corner of the abdominal wall in a minimal invasive and extraperitoneally direction. And we describe our endoscopic navigation abdominal wall with the concept of that all corners of the anterior and lateral abdominal wall could be reached not only minimally invasively, but extraperitoneally. So in a way, we were following the path that was started by Miseré in 2002 that described the lateral access to the retromuscular space. And we had to wait 10 years until Jorge Dias described his ETEP for big inguinal hernias in 2012. His work was followed by Derlin Juarez that described his pre-aponeurotic abdominal wall reconstruction by his REPA technique, but pre-aponeurotic, as you know. And in 2018, the results of the work that they established together between Igor Beliansky and Jorge Dias, they promote this lateral iliac access for ETEP, access for medial or midline hernias, this lateral access to the retrorectal space. Of course, the works of the Rainbow group that describe the Milos, and not only that, but the Imilos in 2019. And by this moment, our group was working in a suprapubic ascendant axis to the retromuscular space, all total endoscopic, that we call Terra. But not only that, but we were working in a medial tip access to lateral hernias until the new access that we've been describing in the last 2 years, that we are going to speak about that. We thought in 2017, when we start thinking about this access, that the infraumbilical peritoneal space was a perfect space for starting this section. We had enough room to put our free trocars and start and ascending this section, and not only because of that space, but because we had a really comfortable access to the midline and to the both lateral spaces. And we start applying and selecting the EHS midline primary and ventral M1 to 4 hernias with a maximum of 10 centimeters, that we're having diastasis. Why not? BMIs, lower BMIs than today, with no gender or age concerns, and using, as you can see, really simple materials. The technique for starting Terra was easy. If you have a dissecting balloon, we use a Lloyd Davis position with open legs, and from 0 to 30, minus 30 degrees of the patient, and we could put our trocars in a really comfortable place with enough room. And we were looking for a critical view, the inverted M that we call, that as you will see here, if you have enough, you have your balloon, your dissection balloon, it is much easier to have this critical view of both retrorectal spaces, as you can see there, bilateral retrorectal spaces, and of course midline, rectus, the Douglas arc, and of course both semilunar spaces. And as you can see in that images, you are able to have a bilateral view of the arcuate lane, semilunar line, retrorectal space, both retrorectal spaces, and both bulgous spaces if you go much further in the lateral, and of course anterior and posterior rectus seat to treat it. And once you have that space created, you're able to go with 2 trocars, as you can see there, to 5 trocars, doing a full midline dissection, not only of the both retrorectal spaces, but the whole midline. You open this insertion of the posterior seat to the midline, and you of course respect the anterior seat, as you see there, and you go dissecting until you find your hernias, and you are able to treat as well the diastasis. You're gonna see here this hernia. In this case, it's an epigastric hernia with a diastasis of 24 millimeters, and there you go. You're able to have a really comfortable access to the reduction of this hernia until you finish the dissection, and you start the reconstruction of this midline. There you go, you finish until you reach the xiphoid, and in that moment you're not able to reduce these small hernias, but as you can see there, you can go up to 12 centimeters, like these ones that you are here watching. All this is done extraperitoneally and retrorectal without opening the peritoneum. It is easy to perform. And once you have treated the hernia, you perform a total midline dissection and tension-free reconstruction, as you going to see here. If you need it, you are also able to perform as much tension release maneuvers as you want. In this case, we are really keen on this Madrid version of TAR that is basically a posterior rectus-sieve release that you are able to perform bilaterally if you need it in order to create a new peritoneal sac and to use really big format meshes if you need it. You see there, you're able to keep intact these neurovascular bundles. There you go in the left side, but you can go also in the right side. As you can see here, you start in a ascending way doing the dissection and the release of this posterior sieve. You can perform a total endoscopic posterior component separation, as you can see there. No problem with that. And get that tension-free release maneuver if you need it. Of course, when you need it, not always, just when you have defects more than 12 centimeters, as you can see there. Okay, no problem with that. And after that, we perform an anterior closure. First anterior closure. After that, we close posterior sheath. We use Borg big format sutures in a running way, non-unservable sutures, and we close not only the defects, but we placate the diastasis until we finish, as you can see there. And once we finish with that, we close. Okay, we can close really big gaps, as you see there. Going down the pressure and applying, if you need it, unilateral TAR, if needed, or bilaterally. You close these defects, as you can see there. And after that, we promote the mesh augmentation. We put big format meshes up to 30 or 40 centimeters. If we have it self-gripping meshes, why not? Fewer non-observable tackers, just if needed, to locate, to extend the mesh. We always use collagen glue for sealing spaces, and drainage is not protocolized, just if we think that we are going to need it. And in this case, as you have here, we're extending a totally observable phase 6 ST mesh that is really a nice option for young women that have any concern with permanent meshes, or if we think that is indicated to the use of it. In this case, so we want something that were totally observable, so we use it after we close the midline, and we put just some observable tack fixing, as you see there. And after that, we close the midline, as you see there, the posterior sieve. No problem with that. And we always use fibrin glue as a space sealer, and no drainage in a protocolized way. There you go. We present our technique in 2019 in the European Endoscopic Congress, Surgery Congress. We present our first 48 patients. We complete our procedure in 40 of them, in the almost 85% of the cases. Just in a few cases, we turn into IPOM Plus or REPA. The median intraoperative time was of 95 minutes. We really realized for the first cases that was a non-really painful technique. As you can see here, the mean VAS in the first 24 hours was 2.5. We have a mean hospital stay of 36 hours. Our recurrence is 0 until now, in a mean follow-up of 40 months. And we have 6 seroma hematoma patients, but none of them required any interventional. We have 2 major complications that we would like to share with you. The first of all was a really obese patient that presented in the second week, post-operative second week, an hernia like this, really huge intermuscular hernia due to this insertion of the oblique, the internal oblique sheath. That maybe there was, of course, a technical problem, but that was inserted. We had an interoblique huge hernia that we solved with an intraperitoneal mesh reconstruction, and of course we used a new approach. We had that interoblique space already dissected, and we decided to put some trocars into it and put another mesh and another closure of that gap. And we use a sandwich technique, minimally invasive sandwich technique, to repair that mesh, that problem. Sorry. We have a bowel obstruction, the second major complication that we have. Bowel obstruction. We left this peritoneum window open, and we have a lack of having an hernia through that window, and we decide to perform an IPOM approach, reduction of the hernia, and we perform an IPOM Plus technique to close this to solve this problem. Today, we apply this technique for EHAs, midline, primary, and ventral from M1 to 3 hernias. We had problems, as we are going to explain, with really infraumbilical hernias with this approach, up to 10 centimeters. Of course, diastasis, no problem going up with the BMI of these patients. We find this is perfect for these bigger VMIs, and we still use single simple material, laparoscopic normal material for this. Our limits for this technique that we are presented is that it is really easy to turn, like an ETAP, extended ETAP, easy to turn hybrid, so it is not a problem to close it, but we recommend to close it until you finish your procedure. It is really difficult for infraumbilical hernias, so we perform an ETAP from the subcostal area to these N4, N5 hernias. If you have any skin cosmetic concerns due to plications in lower VMI patients, it's easy to turn into a REPA, so we promote that. And don't be afraid to put extra trocars for upper defects. It is sometimes really difficult to have a triangulation due to patient legs if you don't put it in the right position. So be careful with that. And of course, we hope we don't have more pandemic surgery cancellations. So that's it. Abdominal wall surgery, endoscopic surgery in 2021. Our thoughts are that other techniques derived from the endoscopic navigation experience will arrive soon. And of course, we are waiting for robotic schemes in the moment that we applied robotic to this kind of surgery, that we are not into it until these days. We would like to present you not only that technique, but our medial TEP approach to lateral hernias, our ascending TEP approach to lateral hernias too, and of course our posterior interoblique approach to lateral hernias, and other techniques derived from our experience in this endoscopic extraperitoneal surgery of the hernias, the medial tip approach and the ascending TEP approach from the suprapubic space or the midline infraumbilical space to lateral hernias, for us is the ideal technique for L2 to 4 up to 10 centimeters lateral hernias. For example, the spigal hernia or combo inguinal and spigelian ipsilateral hernia, it's perfect for this combo. Primary and ventral lumbar and lateral hernias and iliac graft bone hernias that we have some of them. We would like to give you some tips for this. As you can see here, this is a patient that had an accident and had a cyphopubic laparotomy some years ago. She presented a traumatic hernia due to that accident that she suffered. And instead of going into that abdomen with multiple visceral injuries, we decided to perform a totally extraperitoneal access. As you've seen there, it is like a normal tap for a normal inguinal hernia tap access that we apply the same technique. We go through that boggrous to that, we dissect that boggrous space, and in that moment that we have space dissected, we put some more trocars in that midline, and we perform a total dissection of this lateral hernia, as you can see there, that had a slide sigmoid column into it. We dissect it and we perform total closure of that gap with running non-absorbable sutures to barb sutures. As you can see here, it is really much easier to close these gaps in lateral hernias than in midline. That we find out that thing that is like more natural to these gaps to be closed. And once you close it, we perform a hernioplasty with a really big mesh. There you go. You have that gap closed. And after that, we dissect a little bit more and we decide to use a mesh. As you can see here, we use these big format meshes. We really like big meshes that we can tailor to the space that we have created. We don't care if we have some wrinkles in it, no problem. We like to expand it, and we consider that with time it is going to go 30% decreasing its size, so no problem with that. We put just some absorbable tackers, being careful with the retroperitoneum space due to the because we have there the ureter of that place in that side, so be careful with that. We cover until the inguinal hernia space, and we finish. That's it. Our results with this approach is 15 patients. We have complete the full procedure in all of them. We still confirm that this kind of surgery is really a low pain approach, a low pain surgery, and we have almost 7% of serum hematoma with no concerns with puncturing it or putting out, no problem. And we have a mean follow-up of 8 months, and we always perform a CT review 6 months and a year, no problem and no major complication with this. We would like to introduce you a new technique for L4 lateral hernias and ventral lumbotomies. It's really a nice technique for this kind of hernias that is on a posterior approach. We dissect the interoblique space. We put some trocars in it, 3 trocars, and we are able to close this space and put a really big mesh in this interoblique in this interoblique dissected neospace that we create. We call it the Apio technique. Okay, we hope we have some more cases to show you in the future, and of course, new techniques are coming from our experience in putting some trocars in these spaces, not going intraperitoneally. And this TAPR technique that we just described is a new technique for epigastric hernias that we are allowed to put some trocars into the umbilical space, and we dissect this supra pubic paraponeurotic space and perform a surgery that we could be performing in an open approach, but through this scar in the umbilicus that you can see here, that allow us to perform almost the same surgery as open, doing a peritoneal plasty with a patch, like you can see here, but through a hidden scar surgery, okay? What we think in this year with our experience is that we're still tailoring these techniques to the hernia that we are finding. So we hope in few years to have a really clear idea of where are we going through these new techniques. And what we can say now is that Terra is safe and feasible approach to M1 to 3 hernias. The TEP medial approach is safe and feasible approach for AHS L2 to 4 hernias up to 10-12 centimeters. That our interoblique posterior approach is feasible to HS L4 hernias, and that the TAPR technique is really a nice and feasible approach to AHS M1 to 2 up to 4-5 centimeter epigastric hernias. We also would like to say that our endoscopic navigation experience guides to a new chronic subperitoneal approaches, will guide us to these new approaches. And of course, that this endoscopic surgery is really quickly growing, and we promote to make it rational and use our lessons learned from 25 years of abdominal wall laparoscopic and minimal invasive surgery until now. Thank you very much for the time. I really appreciate your invitation to this fantastic meeting, and we would like to have a remembering to our boss, Dr. Joaquin Diaz Dominguez, that unfortunately deceased last year due to coronavirus and left us alone in these days. So we really would like you to have him in your thoughts and have a prayer for him. Okay, thank you very much.
Thank you very much for this interesting presentation. And yes, COVID, there were some victims of it. So our thoughts are with you, Federico. So we're continuing now, going basically in your neighborhood, René. Dr. Bocconi is our next speaker. He is working as a head of surgical department in the Franciscus Spital in Vienna. So I think you both know each other well. Tell us what he will talk about.
Yeah, I'm very eager to hear about his experience with e-Milos, a success story to be continued, extraperitoneal mesh repair of umbilical hernias with combined rectus diastasis. So it's up to you, Herwig.
Dear Chairman, dear René, dear appreciated audience, dear Alexander Erdmann, dear BD, thank you very much. It's a privilege and an honor to be part of this great International Hernia Symposium in the ventral session. And it's another privilege for me to speak about e-Milos, mini for up to 5 centimeter incision or less up to 12 centimeter incision, because this technique was invented and developed by Wolfgang Reinbold. And I started with this technique because I was inspired, and therefore it's called a success story to be continued. And I want to talk now about a special selected group of patients with an umbilical hernia combined with an rectus diastasis. So we will start with some information regarding the technique. I will show you a short video with the steps of the operation, and then finally we will go to the results. So these are my disclosures. And this is something we are very familiar with. This is the classification of primary and incisional abdominal wall hernias. It was published 2009, and we all know that it is necessary that we know about what we are speaking. And so therefore, we are very thankful that there is a classification of rectus diastasis. It's a proposal by the German Hernia Society and the International Endo-Hernia Society. And it shows us that we are talking about a rectus diastasis when it's more than 3 centimeters. You see there are 3 classifications, and when it's more than 5 centimeters, we are in the category 3. This is a publication I want to cite from the last years. I think everybody knows this publication. It was very prominently published in Lancet from Kaufmann and the Jekyll group. And it shows us that even in small hernias, we should do a mesh repair. Hernias 1 to 4 centimeters, epigastric hernias and umbilical hernias, and we should do a mesh repair because in this randomized study, they found significant fewer recurrences in the mesh group than in the suture group. There are further other studies that show us these results, but there's another special study I want to cite from Gernot Köhler from Austria. He looked for a sutured repair of primary small umbilical and epigastric hernias, and he showed that there is a high risk for recurrence if you're not doing a mesh repair. So he suggests definitely to do a mesh-based repair of the midline. And these two publications, together with several other publications, have led to the recently published guidelines for treatment of umbilical and epigastric hernias from the European Hernia Society and America's Hernia Society. And there we can read that there is a suggested algorithm for the repair of these small symptomatic umbilical and epigastric hernias. And as you see in the very small group with 0 to 1 centimeter, you can do in a shared decision with the patient a suture repair with a non-absorbable or slowly absorbable suture, or you do it with a mesh repair. When it comes to 1 to 4 centimeters, you should do a mesh repair, open or laparoscopic. You should have a good overlap, 3 to 5 centimeters, and you should use the space which is favorized in the last years. It's the pre-peritoneal space or the retromuscular space. All hernias more than 4 centimeters, you should treat as an incisional hernia. And furthermore, we have now these guidelines for hernias in rare locations. And there we find, besides the beautiful drawings of Johan, we find that there is a recommendation to use a mesh repair for umbilical and epigastric hernias in patients with a combined rectus diastasis. The simultaneous rectus diastasis repair is optional. And this is where my story starts. And we have to go back to the year 2017, where René Fortelny organized this great and long-lasting, impressive congress in Vienna. And I had the privilege to organize the live surgery together with these very important people of hernia surgery, Conrad Pellissier, David Chen, Philip Moissams, and the man in the shadow, come out, it's Wolfgang Reinpold. And I started with his approval a series in this selected group of patients. And now we go step by step into the operation. You see a patient typically, we did just the suture repair. We had a combined rectus diastasis, and a few months later, he had a recurrence. So this is the first step to know about the Milos technique. You go through the scar. It's a transhernial way to go to the problem. And then the first step is similar to all what we are doing when we do a sublay repair, open sublay repair. We have to look for the posterior sheet of the rectus muscle. And this is, in this case, very easy. In some cases, when you have diastasis more than 10 centimeters, it's very difficult to get into this space. This is done in both sides, and this was not very difficult with this small hernia size. The next step is you have to go on with the preparation towards the xiphoid process and downwards to the symphysis. And you have to cut all these adhesions till you see the arcuate line. You can go on even with long hooks to get to the symphysis. It's not necessary to go more than about 8 centimeters to have enough space to bring in the octoport or the Alexis port, some monoport system for the endoscopic procedure. The next step, you have to close the defect. And we, from the beginning, did reconstruction with a small bite suture of the posterior sheet of the rectus. This is not necessary. It's even very difficult when you have a diastasis more of 10 centimeters. But since we at our center did always an open repair, total reconstruction of the posterior sheet, when there is not too much tension, we did this also in our series. And this is discussed on many congresses and discussed with Wolfgang Reinpold. It's not done everywhere, but we decided in our center to do a reconstruction of the posterior sheet. In the next step, we bring in the flexible monoport system. You can use a single incision system like this octoport or an Alexis port. There are different diameters. In the most cases, you are with 3 centimeters, you can work well. You can even use sometimes 5 centimeters. And then you start with the gas insufflation up to a limit of 12 millimeter Hg. And you go on with the endoscopic procedure of the operation. This is what it looks like in our operations theater. This was a workshop, so you don't need so many people. You just need one for the camera assistance. I stand between the legs of the patient, and then I can do the operation, but I can also move to the left and right side. We have to move the video tower, and you can do preparation in all directions, and you can even go farther. You can do a TAR procedure. So it's very comfortable to work. And now we can go on with the endoscopic procedure. We now do it in the single incision port first, and we go upstairs. You see the rectus diastasis. And after about 10 patients, we changed to another technique. We put 2 5-millimeter working trocars, which we put laterally to the rectus muscle. We have control on the side not to do harm to the vessels or to the nerves. And then it's much more comfortable for the surgeon to go on with the operation. You will see now with the fast forward speed, the preparation you see above the rectus diastasis. This has to be you must not destroy this. You see below the preperidural fat, and you go until you see the fat that's covering the xiphoid process, then about 3 centimeters, and you have reached the place to put the mesh. So this is what we are doing to have a good coverage. And in the next step, we go further with the lateral preparation. Be careful not to make harm to the vessels and nerves, something we know about since we are doing open supply operation. So then we start with the closure of the posterior sheet. I told you this is not done in all the centers. To me, it's much more comfortable to do this suture than the suture of the anterior sheet, because I'm used to this kind of technique. We need about 2 to 3 sutures from this self-arresting suture. It's the V-lock. It's a 2.0 suture, slowly resorbable. And as you will see, when you have done this completely with 2 to 3 sutures, you have a complete reconstruction. There's no tension, and you can now go on to do further preparation in the lateral compartments. The next step is, and this is a very important step, as we know from modern hernia surgery, is to reconstruct the midline. You see, this technique is more complicated. You have to do a kind of plication to get reconstruction with the linea alba. this is very easy when you have a good subcutaneous tissue in fat men, but when you have thin women, you will have not very good cosmetic results. So you should change the technique, because there will be not that good results you want to have. As we use about 3 sutures, we reach here the ring of the monoport system, and then we go on with the open technique. After changing the gloves, we put in the mesh. In this case, we use the Phasix mesh. The patient was very well informed. He wanted not to have a permanent mesh, and I think it's a very good indication to use the Phasix mesh. If you want to save money, you can use naturally every polypropylene mesh, but you can put in a big mesh. This mesh is 40 to 12 centimeters. And after preparing the mesh, after measuring the size you need, you can bring in this mesh. And you will see now it's done with long clamps, and you will get to the Xiphoid process. The mesh can also be a self-gripping mesh. There is no preference to this. It's like you want to do it at your center. And after the mesh is placed, now you go on with the endoscopic part of the operation. You have to look for the good coverage, the coverage to the Xiphoid process, also to the symphysis bone, to the space of retius. And then when the mesh is exactly positioned, there's no wrinkling, you have an exact result as you want for this operation. Some words for the Phasix mesh. We all know Phasix is a very good mesh, even if you use this biosynthetic mesh in a cohort at risk for complications, as John Scott Ross has shown us with his 3 years results. We are waiting for the 5-year results. And I found this very recently published study with the long-term outcomes from Well, where he compared the results of the biosynthetic Phasix mesh with the cadaveric mesh group. And he has also very long-lasting, long-term outcome results. So I think this is a very good indication for the Phasix mesh. Finally, we have to reconstruct the anterior sheet of the muscle, of the rectus muscle. Therefore, we take the Wheelock suture and we are knotting this together with another slowly resorbable suture, and we're doing this in the small bites technique. And then finally, is the complete reconstruction of the midline, one of the principles of modern ventral hernia, which you should always have in mind. So finally, when you have done this part of the operation, you have just to do the fixation of the umbilicus and the skin sutures. You can also do an intercutaneous suture. And in our last view, now you can see what modern hernia technique is able. We have a big mesh through a small incision. We have complete overlap. You see a slightly bulging. This is due to the reconstruction of the midline. In midline, this is in men with enough subcutaneous tissue, no problem, and it's vanishing about the months. But in women, there will be not cosmetic really satisfying results. You should change your technique to a Mila or ELA technique, or you have to do a subcutaneous mobilization. You see a drainage, which is placed in the retromuscular space for 3 days. These are our results till today. We presented our results at the Congress von Wolfgang Reinbold in Hamburg. These are 55 patients, mainly these are men, age in the median 61 years. The hernia size 2 centimeters, diastasis 5.5 centimeters, and the median mesh size 40 to 12 centimeters. The incision line 4.5 centimeters We take about 2 hours for this operation. The patients stay for 5 days. We had just one patient with reoperation due to a hematoma. We had to do a reoperation, take away the hematoma, make a change of the mesh. Postoperative pain scores are very low with a median of 2. And these are the well-known results published from Wolfgang Reinbold in the Annals of Surgery. He did 615 Mylos incisional hernia operation, and he performed the match paired analysis. And he could show, compared with the laparoscopic IPOM incisional hernia operation, that he had significantly fewer postoperative complications, fewer general complications and recurrences, also less chronic pain. And compared with open supply, he could also show significantly fewer postoperative complications, reoperations, infections, complications, recurrences, and less chronic pain. And finally, this technique can be advanced, as he has shown us again with the TAR procedure. I told before in this presentation that you can also do an endoscopic TAR operation. He did 54 cases of Mylos and 35 cases of endoscopic Mylos. And he had just 3 infections, 4 hematomas, 1 bowel obstruction, and an injury in the bowel that was sutured, just 1 central mesh rupture, 1 subxiphoidal recurrence, 2 suprapubic recurrences, and chronic pain rate of 5.2%. So finally, thank you very much for the privilege to talk about this very interesting technique, a technique that is proceeding with small modifications. For me, it's a nowadays established technique. And I will go on with my series. I want to go to publish this, and I want to go to the incisional hernia 2. One last slide is now coming. One thing is very important to all of us: when you do something new, you should have a good instructor and a good learning curve. Otherwise, if you try something new you are not really prepared for, you might have bad results, as in this case. Thank you for your attention.
Thank you, Dr. Bocconi, for this update on one of the latest techniques. And we're now moving further to Germany, and we have Dr. Ficatas from University Hospital in Berlin. Charité, he's there, the head of hernia surgery and complex abdominal wall reconstruction. And please, René, what will he talk about?
The topic is less pain, less cost, the ventral TAPP procedure compared to laparoscopic IPOM for small and medium-sized hernia.
That's
so
very well, and the rest of the topics.
Yeah.
Let's have a look.
Great.
Thank you very much for the invitation, talking about our study regarding ventral TAP repair versus laparoscopic IPOM. This is a Berlin study with a propensity score matched analysis of these 2 techniques for small and mid-sized ventral hernia repairs. Regarding hernia repair, there is several layers suitable for hernia reconstruction. The only surface on the surface behind the rectal muscle, the sublay layer, and between the rectal shunt and the peritoneum, the underlay, and last but not least, the interperitoneal mesh placement with the IPOM technique. 10 years ago, the study from Helgstrand showed that the most suitable repair for incisional hernias was mesh placement in a sublay position. So everything thought that this is the most suitable technique, a sublay repair for incisional hernia. But current studies with almost 10,000 patients showed that lap IPOM repair has some advantages, like the short hospital stay, the less postoperative complications like wound infections and seromas. Despite that, there are some disadvantages with lap IPOM technique. More intraoperative bowel injuries may occur, and of course, this technique is not suitable for larger hernias with a diameter over 10 centimeter. But of course, can we talk about one single technique for all hernias? Is it suitable to use the identical technique for a small hernia like shown on the left side? as the large hernias on the right. And the paper regarding the guidelines for laparoscopic treatment, in 2014, the question was raised if the tap or tap technique could be used for small and medium-sized hernias, because it would be accepted that these techniques cause minimal trauma. The surgeon is using a standard mesh with minimal fixation. The hernia is being removed from the abdominal wall, and the defect is closed with an anatomical reconstruction of the abdominal wall. So in our study, we compared minimal invasive techniques of repairing small and medium-sized hernias. So we compared the underlay versus the intraperitoneal layer for a mesh. So we included in our study 118 laparoscopic ventral hair repairs. We excluded all the hernias with a size of more than 5 centimeters. So 64 patients were left, which were treated with a lap IPOM or ventral tap repair. Out of these, we made our propensity score matched analysis with 27 patients in each group. So our preferred placement for the trocars was the on the left lateral side. We started the pneumoperitoneum by putting a trocar at the palmus point with the letter A at the graphic. And this is a video of the intraperitoneal repair with a ventral tap technique. First of all, the first step is to dissect the peritoneum, paramedium, and release it from the dorsal rectal shelf. After that, we remove the preperitoneal fatty tissue, which was inside the hernia sac. This can be done with forceps easily and atraumatic in most cases. After that, the preperitoneal sheet has been dissected to the contralateral side of the surgeon. This can be also done with manual preparation. One big advantage of the ventral tap technique is that during this reconstruction, we can also see some other lesions and hernias besides the primary hernia, like here with a secondary hernia in the epigastrium. Our experience is that in some cases with IPOM repair, the surgeon is not aware of a second hernia, and so he covers the second hernia with an IPOM mesh, and but the patient still have this preperitoneal fatty tissue inside the abdominal sac, causing pain even it has been repaired, referring to us for a secondary surgery. So here you see the closure of the fascia defect. We perform this with a sliding knot. It's a special technique of us with a self-locking sliding knot with interrupted suture. We use a polyester yarn USB-O. By using this sliding lock, it's a time-saving technique to perform really strong knots. We have done our tests in the lab, and with an USB-O polyester yarn, we reach up to 40 to 45 Newton tension with each knot. So by using 2 or 3 knots, there's enough strength to closure the abdominal wall even after the surgery and holding during conditions like coughing or pressing or lifting weights. So you see the interrupted closure of the 2 defects. And this defect closure is performed under keeping the pneumoperitoneum at 15 centimeter of water. So after that, the mesh placement between the peritoneum and the rectal sheath. The mesh is a polypropylene mesh. It's been placed like in the TAP technique for the inguinal hernia repair. And after that, closure of the peritoneal shelf with strata fix or V-lock or quill yarn. So during this procedure, the intra-abdominal pressure is been lowered to 8 centimeters of water. So finally, the mesh has been covered. So to the data of the patients in both groups. So there was no differences regarding age, the gender, the BMI of the patients, or the ASA classification. So most patients were around 55-year-olds and with a BMI a little bit over 30. And most hernias were primary ventral repair. We had some incisional hernias like trocar hernias in both groups, but there was no significant difference in the distribution. So that's why we could perform a propensity score matched comparison. And the mesh size was equal, almost equal in both groups. The mesh size in the IPOM group was a little bit bigger. This is explained because we use the already preformed mesh, and we do not reduce it or cut pieces away of the mesh. Instead, in the ventral tap technique, we cut the mesh into a suitable size. What is really impressive is that the material costs with the ventral tap technique are much lower compared to the IPOM technique. So the saving is about 700 euros, over 700 euros. So, and regarding the postoperative results, it was impressive that the pain after the ventral tap repair was significantly lower compared to the laparoscopic EPOM repair. Of course, because there are no tags in this technique, because the mesh is placed with no glue or tags in the sheet between the peritoneum and the rectal sheath. So this doesn't cause pain to the patients. Another incredible detail is that over 50% of the lap IPOM patients needed to take some opiate as a painkiller after the reconstruction. And the ventral tap group, it was only 11%. So this is also another sign that the ventral tap is a less painfully procedure. And of course, regarding the hospital stay, it was shorter significantly in the ventral tap group with a half day of a lower hospital stay. I have to confess, this is combined with a German health system that pays you only if the patient stays 2 days at the hospital. Otherwise, you have a lot of cuts in the end payment. Our experience is that after a ventral tap repair for a small hernia, the people could even leave home at the same day. So in a lot of cases, we just try to convince the people to stay a little bit more just because of the system and the reimbursement system for the hospital. So in conclusion, the ventral tap procedure is a promising alternative technique to lap IPOM repair for abdominal wall hernias for less than 5 centimeter size. This technique is technically demanding and a method for more experienced laparoscopists. But if you use the ventral tap technique for small hernias, the postoperative pain and the opiate intake is significantly lower compared to the laparoscopic IPOM repair. And of course, you save a lot of material costs and the patients have a shorter hospital stay. So I do recommend the ventral tap procedure for small hernias, but of course you have to consider it that this technique doesn't fit for all surgeons and for all type of hernias, because a hernia operation is like a visit to a good tailor. Thank you very much.
You are mute, Alex.
And we are now having Dr. Möbius, Dr. Messager, and Dr. Mussons and Dr. Chatzimarvoudis, who will share a case with you, and we will discuss in this little panel what would the experts do. And we're starting with Dr. Möbius.
Yeah. Hello, everybody. I'm very happy to be here with you. I would love to be with you in Greece, but I'm in the rainy Germany. So I start with my case. Hopefully, can you see it?
Yes.
I need some help.
Can
you see?
We can see it now.
Can you see the case?
Yes.
Yeah, because I can't see it by myself. Okay, what we have here now.
Maybe you open it in a different window.
Yes, I did so, but I can't move the slides. I'm sorry.
One second.
Why can't I move? I'm sorry.
Just go with mouse maybe from slide to slide.
Yeah, that's what I'd like to do, but it doesn't work. It doesn't work. I'm sorry.
You want to open and close it one more time? Or
Yes. I'm sorry.
Maybe we go first to Chatzimarvoudis. Are you ready that we maybe start this one first?
Yes, I'm ready.
Dr. Möbius, we're coming back to you in a second.
Yeah, I'm sorry. I have technical problems here. I'm very sorry for that, but it doesn't open. I don't know why.
Okay.
So I'm sorry for that.
You want to share my screen?
Yes, please.
Okay.
Was ist das?
Please mute everybody when
Can you see my presentation?
this is now presenting.
Okay. Can you see my presentation?
Yes.
Okay. Good evening, everyone. Once more, I would like to say that it's my pleasure and honor and the privilege to participate in this extraordinary, fantastic, actually, event and to be with all of you. I'm going to present you a quite interesting case. It has to do with the management of a patient with acute mesh infection. It's a 73-year-old man with no significant comorbidities and a history of laparoscopic incisional hernia repair, actually an IPOM plus an open left inguinal hernia repair at the same time that took place 15 days ago. On the 9th postoperative day, the patient presented with symptoms and signs of surgical site infection at the area of the incisional hernia. The patient conducted his surgery and he started antibiotics. On the 15th postoperative day, he presented to the emergency department of the hospital with worsening signs, with sign of sepsis, actually. And here you can see the area of the sepsis, the area of the infection, of the inflammation. Here we can see I have mentioned where the mesh was implanted in the previous laparoscopic operation. We decided to go to do an urgent CT scan. And here you can see the CT scan. Here you can see all the signs of the surgical site infection. Covers the adipose tissue and the muscle layers. That means that it's a deep surgical site infection. According to the clinical situation of the patient and the CT findings, we transferred the patient to the operating room. And here we can see we did a midline exploratory laparotomy. After that, after dissecting the subcutaneous tissue, we came in front of this very difficult situation. You see a pus, loose stitch that was the stitch suture that was used by the surgeon in order to close the defect during the laparoscopic approach. And here we can see the video. We can see actually the mesh that is swimming in an ocean of pus. Of course, we did samples to send for a culture. And after that, we decided that we could not salvage, of course, the mesh. We have to remove it. So we removed all the mesh, as you can see here. Here, all the mesh was completely removed. And after that, we wanted to inspect, to check the abdominal cavity to see what was happening. And we saw this thing. Actually, what we saw was an area of the small bowel where it had these findings. We strongly believe that the origin of the infection was an accidental injury of the small bowel that took place during the laparoscopic repair of the hernia. So we decided that we could not salvage these loops of the small bowel. We had to resect it. We did a side-to-side anastomosis. And so we are in a situation in which we have totally removed the previously planted mesh. We have done the small bowel resection. We have done local debridement. We have done the side-to-side anastomosis. And now we are in front of a big defect, much bigger than the defect that the previous surgeon had worked on, because we don't have just the defect of the previous operation of the previous hernia. We have a bigger defect because of an infection of a distracted soft tissue due to the surgical site infection. And the question is, what should we do next? I'm waiting for your suggestion, for your thoughts.
Yeah, this is the first part. Thank you, Grigoris, for this nice case. So we have to have a little discussion about, Christian, what would you do in this case?
Yeah, I think I would follow him. I would do the same. You just have to look afterwards, and I'm very impressed that you present such a case, because everybody knows we have such cases, even if we don't want to have it. So no mesh, just repair.
Okay, Mathieu, you have a comment on that, please?
Yes, I quite agree with the previous situation. I think I wouldn't put a mesh with regard to the risk of major infection, so I would do just a simple closure.
Yeah, Philip, what's your preferring method?
One of the questions, of course, is if you can close it primarily like the two others recommended, you could, but it looks like a defect that's going to be too big to do primary closure, and then you come into the treatment options for open abdomen treatment, where you try to do some medialization and traction, maybe with a VAC system on top, which we don't do very often in our hospital. So probably I would refer it to the university over here, where they have a large experience with this medial traction. So in my setting, this would be referral for such an approach.
So you wouldn't like to have a closure without or with mesh? You would just transfer the patient.
First thing, if it comes together and you are able to close it without undue tension, then that would be my option. And then do a second.
Then a VAC system in the subcutaneous.
Yeah. But it doesn't look like it's going to close, I think.
Okay, thank you. So, Grigoris, what's the solution?
Actually, Philip has 100% right. We could not close this big defect. So what we did is we left an open abdomen. At that time, we used a Bogota sac in order to cover the intestine and the viscera. I know that we could use a VAC system, but in our hands, we see that by using this Bogota sac, which is quite a very cheap way to handle an open abdomen. It is very easy to do it. It's very safe and very effective. So first of all, we put a Bogota back into the abdominal cavity. Then we try to close, to reapproximate the midline. Of course, there was an area in which we could not close it. In order to prevent abdominal wall retraction, we used a vicryl mesh, which we sutured at the edges of this big defect, and we closed the midline with the skin, putting some drains, as you can see. This is what we did at day 0. 10 days later, we went once more to the operating room. The patient was not septic anymore. He was in a very good condition. So we went to the operating room once more. We reopened the wound. We removed the vicryl mesh. We removed very easily, as you can see, this Bogota sac. This Bogota sac does not create any adhesions at all to the viscera. We inspected the abdominal cavity. We saw that we didn't have any leak from the anastomosis or any abscess, any other collection. So what we decided to do, we decided to reconstruct the abdominal wall. We did a TAR technique, as you can see here. This is the left side of the patient. First of all, we went to the left retrorectus area. After that, we did the transverse abdominis release, and we entered the lateral area between the transverse abdominis muscle and the transversalis fascia and the peritoneum. This is on the right side. We managed to close quite easily, without tension, the 2 posterior rectus sheath. After that, we used this device, as I'm going to show you here. This is a device that actually we shared from the orthopedics, and you use it in order to do a dynamic mechanical washing out of the abdominal wall tissues by using a solution which is a mixture of 3 types of antibiotics. And then we had to decide what type of mesh we should use, because we believe we could use a kind of mesh. In general, in my current practice, I'm using this modified Hernia working group classification system in order to grade the patient side according to the risk that they have developed surgical site occurrences and surgical site infection. For grade 1 patients, just permanent synthetic mesh. For grade 2 patients, according to the number, the types of comorbidities, permanent synthetic or biosynthetic mesh. For grade 3, for clinical contaminated cases, biosynthetic or permanent mesh, and for dirty cases, just biosynthetic mesh. The case that I presented was grade 3 dirty case, so we decided to use a phasix mesh. We placed a huge piece, 50 by 50 phasix mesh at the retromuscular area. Then we tried to reapproximate the midline. Despite the fact that we did TAR technique, we could not reapproximate 100% the linea alba. So what we did, we placed another mesh, a biologic cross-linked mesh, just to cover the phasix mesh. And here you can see at day 10, the day of the second operation, the picture of the patient. This is 10 days later. This is 1 month later, and this is 3 months later. No signs of infection, or size infection of the soft tissue or of the mesh. The patient is in very good condition. Here you're going to see at 6 months follow-up, the patient is in great condition, no signs of recurrence. And just I would like to close with the CT scans. At day 0, you can see this extended surgical site infection. 3 months later, no signs of infection, just a small seroma at this level of the CT scan. You can see 3 months later, at 6 months follow-up, it has almost 100% fully absorbed. So this was our case. I hope that you like it.
Thank you, Grigoris. Nice case to start with the next one. So, Christian, are you ready to present your case now, or should we go to Mathieu?
Yeah, we can just we try again. I have no idea what happened. I would just try again. Can you see my case now?
Yes, we can.
Okay, perfect. Okay, I would like to present the medical history of a 66-year-old male. He has a diabetes, hypertension, and is a smoker. For him, it was done a Hartmann procedure after perforated sigma diverticulitis in Thailand. Then we returned to Germany and came to our hospital in January of this year. We did a stoma reversion, and in April he presented with this giant hernia. I have done these 3 pictures for you, and I have discussed with my team what to do. And first we did the CT scan, which is presented here. It's not a video, it's just 2, I think, representative slides where you see that the rectus muscle is far behind. And in my team, we had different suggestions what to do. Question was, should we do a double mass sandwich technique? Should we do a component separation technique? If yes, should we do it anterior? Should we do it posterior? Should we do it endoscopic assisted? And finally, what mesh should we take? Should we take like a regular alloplastic mesh or maybe a biological or biosynthetic mesh? And I would refer the question to you. What would you do in this case?
Thank you, Christian. So we have the questions to the panelists, starting with Philip. What would you do in this case?
So I think in this case, preparation with Botox would be on my list, and then probably I'm usually doing posterior component separation, and I would during the surgery it would be an open surgery for me. Although you know that most of my surgery is minimal invasive, probably this is too wide for a minimal invasive approach. It would be an open approach with a bilateral component separation, a bilateral TAR, but keeping part of the hernia sac intact to be able to use as a flap system, like with the Edinburgh technique, if needed, after the component separation, and then use a synthetic non-absorbable mesh, a big one.
Okay.
So what would you do, Mathieu? What's your option to solve the problem?
It seems like a very challenging case. It's quite complex, and I'm not sure to have the right answer to this question, but what I would do maybe is try to optimize the situation before the surgery, maybe with weight loss and cardiorespiratory preparation, and probably anterior approach as well. That would be my view on this challenging case.
Grigoris, what's your choice to start?
I agree. First of all, it will be important to do a preoperative optimization of the patient. Then I would do a posterior component separation in order to close the posterior rectus sheath 100%. And then I would place a mesh, because this is a clean case, despite the fact that the patient has a lot of comorbidity. This looks to be a clean case. So I would choose a permanent synthetic mesh. And in case I was able to close the anterior rectus sheath, that would be the end. If I could not close the anterior rectus sheath, maybe I put another piece of mesh just to cover the mesh that I had implanted the retromuscular area.
What about Botox and PPP? Is this also an option?
Regarding PPP, I don't have experience, but regarding the Botox, I have some experience with conflicting results.
Yeah. Mathieu, do you have experience with PPP in those patients, and together with BTA, with Botox?
Yes, I didn't want it to talk about PPP, not to deflourish what would happen next, but maybe that would be an option. Clearly, okay. I think we need to have a measure of the volume of what's in the hernia sac, and that would help. Yes, I think it would definitely be an option, and that was something we would discuss in our MDT meeting for the PPP technique.
So, Christian, what's the answer?
Christian, you have to unmute yourself to talk, to give your solution. You have to unmute yourself, Christian.
God. Yeah.
Now we hear you, and now you have to share the screen again.
Yeah. Okay. So yeah, we have no. Everything is okay. Can you hear me?
Yes. Yes.
Okay. So we have no experience with Botox so far, and as I told you, this guy has his perforated sigma diverticulitis in Thailand. So we talked about stopping smoking. We talked about lose some weight, but that didn't work at all, to be honest with you. And so we just operated him. And what we did first is we identification of the hernia sac. Then we did the division of the transverse abdominis muscle, which is shown in the picture on the right side, and detached it from the fascia transversalis. And as you see on the next slide, then we were able to close the rectus sheets. We could reproximate it. And the thing we may discuss is we decided to take a Phasix ST mesh in this case, because we have done meanwhile about 15 to 20 procedures like this, and we have sometimes problems to close it in the bottom of the hernia, and so we have to restitch some holes. And to be honest with you, if I have to close the posterior rectus sheets with some additional stitches, I feel more comfortable to use a Phasix ST mesh because I'm always afraid of having contact of the bowel with the mesh. So that's how we decided to repair this hernia. And last Friday, I saw him again. It's like 3 weeks after the operation. He's doing fine. He's feeling well. And that's what he looks like. So thank you. Thank you very much.
Thank you, Christian. Nice case. So we are coming to the next case of Mathieu. Would you start your slides?
You have to fix something with your microphone. We're not hearing you completely. Maybe something is not 100% connected.
Hello, can you hear me now?
Yes.
Yes, so I'm trying to share my screen.
Yeah, it's there.
Okay. Can you see the presentation?
Yeah.
Yes, we can see it. Yeah.
Yes, so I'm very happy to introduce you this complex hernia recurrence repair. So the case presentation is a 65-year-old woman. She has comorbidities, quite classic in big hernia, type 2 diabetes, obese, high blood pressure, and her history is numerous C-sections. She had both vertical and horizontal incisions. And she had a hernia repair 30 years ago, but there were no information at all available in this condition. So I'm going to show you the CT scan that we did when she first arrived. So fortunately, there was no skin infection, or there was a good skin condition. She had a very low quality of life, as you can imagine on the CT scan. So the conclusion was that the collar was quite large, 7.7 centimeters. And we had a measurement of the volume of the hernia compared to the total intra-abdominal volume. And as you can see here, there was more than 20% of the hernia volume outside of the abdominal wall. So this is my main question. What would be your surgical strategy for this case?
Okay, thank you. Grigoris, what's your opinion about that?
very challenging, very difficult case actually to treat, to manage. As I don't have experience with PPP, so it will not be an option for me. I could use Botox in order to have to gain some centimeters, about 3 gain with Botox 3 centimeters per side. But I think I would do a posterior component separation, placing, of course, a mesh. The problem is, and what's very important, to do some things because if you manage to reconstruct 100% the abdominal wall, the problem is that there is increased risk of increased intra-abdominal pressure, and you have an abdominal compartment syndrome. So I think it's very important to prevent this. For this reason, we have to collaborate during the operation with the anesthesiologist, what I am doing, to ask him to give as less liquids as possible in order to prevent edema of the viscera. Second, what I'm doing is I do mechanical preparation, bowel preparation before the operation in order to reduce the total volume of the small or the large bowel. As I told you, I do component separation technique. And of course, I'm putting a nasogastric tube. And at the end of the operation, I'm asking the anesthesiologist to check the plateau pressure to see if it's above 6 centimeters of water. I ask him not to extubate the patient, but to send him, to transfer him to the ICU, intubated, in order to give time to the patient to tolerate, to adapt to these new conditions.
Okay. Do you measure the intraoperative pressure in intraperitoneal? Do you measure that routinely in those patients?
Yes, yes, we do.
Okay.
When we think that there is an increase, yes, we do. Yeah. Especially 100% when the patient is at the ICU.
Okay. So, Christian, what's your option?
Yeah, very interesting case. Difficult to decide. I'm also with the component separation. We would do that too, but we still don't have any experience with Botox. But I think this would be a case we have to start with. We might also think about bowel surgery. So maybe you have to do a hemicolectomy right or something like that if it doesn't fit at all. This could be something you might have to think about.
Okay. Philip, your solution.
Well, I didn't see the CT scan in the presentation for some reason. Maybe it's my computer, but the from what I hear is that my main focus would be on that very high BMI that the patient has to really, in my opinion, a significant weight loss is creating so much possibility and laxity of your abdominal wall that it's even much more important probably than Botox or a pneumoperitoneum. So weight loss, I would really go for weight loss in this patient, even presenting possibly bariatric surgery as a preparation for a definitive repair of the hernia.
Anybody of the panelists have any experience with fascia TENS? This is the traction, you know, the new method for doing approximation. In those cases, there are some reports just for discussion. So what was your solution, Mathieu?
Yes, well, this discussion was very interesting, and we decided to do the PPP technique. So the aim was to have a very strong pulmonary conditioning. So she was referred to one of the colleagues with 4 to 6 weeks of intense conditioning. And it was also often this patient was referred as last chance repair because she saw many surgeons before coming to our center. And so we thought that it was the best technique to solve her problem. So before doing this operation, we did a colonoscopy to check if there is any chance to do a colonic resection. Many exams, information, and we try also to ask her to do an important weight loss, but it was quite difficult. So I'm going to show you the CT scan where we put a Portacat catheter inside the abdominal cavity, and we use room air to inflate the abdomen every day. Regarding the mesh choice, we decided to use a Phasix ST mesh because the risk of infection that was quite important in this technique. And it was also a new technique in our surgical department. And I would like to thank you, Johan, Rona, who helped us for this training and education. We used a large mesh placed in intra-abdominal and with resorbable fixation. So after, what is quite interesting is a CT scan after the PPP. So we inflated 8 liters in total of air. And what you can see here is that first, there is a large volume now that is taken by the air. And also the liver has left some space as well. And as you can see also the muscles, there is a lengthen in the muscles as well. So she was transferred the day before surgery to ICU to receive a peridural anesthesia and also help with the oxygen preparation. And then we did the operation. As you can see, the length of muscle was very maximized. We use a compartment separation technique. We use aponeurotomy, and we resected the great omentum to gain some volume. So this was a CT scan after the operation on both axial and sagittal images. As you can see, we have a nice repair of the hernia. Well, 6 months later, she had no recurrence, but unfortunately, at 17 months, there was a recurrence. So I decided to do IPOM procedure. And as you can see here, there's the previous mesh that was almost degraded. And so for now, she's symptom-free. So it was quite challenging, but fortunately, she's happy after this surgery. Well, thank you very much for your attention.
Thank you, Mathieu. A very nice case. A lot of discussion how to proceed with the different techniques, but this was a recurrence due to the overlap was too less. What was the reason for the recurrence?
I think it was.
Sorry, you're still very hard to understand. Maybe we go further to Philippe's case.
Okay, Philip, it's your turn, please. You have to unmute.
I think Mathieu has to stop sharing, otherwise I cannot share.
Yeah, please, Mathieu.
I'm trying.
After that, the case presenters will be definitely also on the chat. If you have any questions, ask them now in the chat and they will come back to you to answer your questions. So now, Philippe, I think you can. Yeah, we can see it. Perfect.
You see me?
All good. Go ahead.
So, okay, thank you for the invitation and being part of this unfortunately virtual environment. So I like to present the case, not that big a hernia like the previous cases, but it's a 65-year-old patient that had 93. Yes, this is indeed almost 30 years ago for those amongst us. The patient had a total proctocolectomy with a permanent ileostomy. The diagnosis was put of Crohn's disease. Of course, no way to check that now. He had one episode of small bowel obstruction in 2017 that was treated conservatively. He had some comorbidity, some overweight, but not that extensive. So now he comes with a painful swelling in the left flank, and he had a CT scan, which, yes?
Philippe, we can just see half of your screen. Maybe you'll go back just into the presentation itself, and maybe, yeah, that's better. That's better. Move it from there. It's better. Otherwise, it's cut.
I share my screen like I do every time, and somebody has to unmute because I have a lot of background noise. So shortly, almost 30 years ago, total proctocolectomy, permanent ileostomy. Now he has a painful swelling in the left groin, and on CT scan there is an interesting here is that this is a CT scan that really shows the need for doing Valsalva when you do your CT scans for abdominal walls, because here you see that when you didn't do the Valsalva, you didn't really see the Spigelian hernia, and there's the on the right side there is the para-ileostomy hernia. This is a clinical picture of his ileostomy. He also had some granuloma that was sometimes bleeding a little bit. So we also thought that maybe during that surgery, we would also do a small revision of the stoma itself. So Renee, it's up to you. Renee, we don't hear you, you're muted.
Yes, the question is how to proceed. Mathieu, what's your option in this case?
Yes, I'm sorry I didn't follow very well the CT scan before. I think I would try to do a lap IPOM if I read the case correctly.
Okay, Christian, what's your option?
Yeah, I didn't understand. Was it an open proctocolectomy or was it a laparoscopic proctocolectomy? Maybe this
93, so it was open,
oh.
midline with
yeah.
a permanent ileostomy.
Yeah, so I think I would try to do an IPOM, but I'm not sure if it really works if you have this long midline incision. So if an IPOM works, it's fine. If not, I would do an open repair and also reverse the ileostomy.
Grigoris?
Yeah, his colon is gone and his rectum is gone, so there's no reversal.
Yeah, but the ileostoma doesn't look well, so I think you have to correct this as well, don't you?
Yeah, sure. That's one of the things that we added to the treatment.
Yeah,
but you cannot restore the continuity. I thought that was what you meant.
No. Just to correct the stoma.
Yeah, I agree.
Okay, Grigoris.
Well, first of all, if I understand, we have a patient with two hernias, one on the left side, one the other on the right side. First of all, I wouldn't like to do it as an IPOM. I wouldn't like to have a mesh to be in contact with the viscera because the patient has a history of Crohn's disease. You know, this increases the risk of fistulas. So what I would do through open approach, I would go to the preperitoneal area. I would do a TAR technique, not because the patient has big defects, because I would like to go as lateral as possible to put one mesh to cover both areas, both hernias on the left side and right side. After that, I would close the midline and then I would place another piece of mesh just around the ileostomy as a double keyhole. This is what I'm doing in my practice with actually very good results. And the type of mesh for the one that I would place in the preperitoneal, in the retromuscular area, I would place a very lightweight mesh. And for the mesh that I would put as a keyhole around the ileostomy, I would place a phasix mesh. So it's a double keyhole, one phasix mesh and the other biosynthetic and the other non-absorbable.
Okay, Philip, what did you?
So I actually prepared a small video on what we did. And as you might expect, those who know me, that I like to do this minimally invasive using the robotic platform. So we started with incision in the upper abdomen and did some adhesiolysis. As you saw, there's some adhesions going all the way up to the upper abdomen. Although the incision from almost 30 years ago is in the lower abdomen. Then obviously using the robotic platform with the visualization and the wristed instruments to do the adhesiolysis that's needed. This is the midline, a bit weakened, but not really a hernia there that needed treatment. So this is the Spigelian hernia, which I think when I look at it is a primary Spigelian hernia, which was actually the reason for the patient to come to us because of pain and discomfort there. So we plan to do a preperitoneal repair because we want to keep the mesh outside of the abdomen if possible. And I think this is basically, it's just a bit higher and lateral to the epigastric, so it's more or less comparable to a groin hernia. Here you see nicely that this is a real Spigelian hernia, so the external oblique muscle is intact. You see that in the bottom of the hernia defect. So we close the hernia defect, and we've placed a large pore polypropylene mesh in the preperitoneal space, which covers the mesh by at least 5 centimeters in all directions. And we fixed the mesh with just a few vicryl sutures just to keep the mesh in place until ingrowth has occurred. So this is on the left side, and obviously the nice thing about this robotic platform is that it's just the same trocar positions. You just turn the boom to the other side and the robot to the other side to tackle the ileostomy hernia. And like one of the other presenters documented, we were a bit afraid of putting a synthetic mesh in contact with the ileostomy, where previously supposedly there would have been inflammatory bowel disease, although at this moment this small bowel looks quite fine. So the idea is to do a non-slitted mesh, so what is commonly referred to as a sugar baker technique, but not in the peritoneal plane, but in the preperitoneal plane, doing extra peritoneal repair. And this is often referred to as a Pauli repair because Eric Pauli published that. So this is the phasix mesh. The cross is where it will go to the pubic bone. And I did put just to fix the mesh in place first with a few tackers, and then with using the robotic facility to suture the mesh with a suture. Obviously, an absorbable suture. Since I'm using an absorbable mesh, it doesn't really make sense to use a non-absorbable suture. And closure of the peritoneum. So I think actually the case nicely shows the versatility of a robotic platform to treat trocars. In the end, we decided to do a revision because I wanted that's granuloma out and also some anatomical pathology on that case. That was good actually. There was nothing wrong with that granuloma.
Thank you, Philip. Very nice case and perfectly done. So we go on.
So once again, everybody who has questions to the cases, the presenters of the cases will be still available on the chat. So ask your questions and you will get your answers. We are continuing now with a little bit of a different topic, not talking so much about cases. We have Dr. Jacob now presenting about importance of social media for hernia surgery. So let's have a look at this, a little bit of break from the procedures.
Good evening, good afternoon. This is Brian Jacob from New York City. Thank you so much for the invitation to give this lecture about social media for surgical education, post or perish. It's a true honor. I have been very, very passionate about social media and its use for the widespread global dissemination of surgical education with the main intent to optimize patient outcomes since the last decade, and to see how much it's grown and to see how well it's been incorporated into many of your lives is truly heartfelt. So it's an honor to give this lecture, and thank you, Bard BD, for having me at Hernia U, a truly remarkable endeavor of its own. So these are my disclosures. as far as being a paid consultant for BD, as well as some of my other previous assignments, none of which will affect the content of this forthcoming lecture. And if I do my job correctly today, you will learn something new, either about the value behind using social media for surgical education, or perhaps getting rid of some of the myths you may have about it. I want to start with a brief introduction to ask you if you know who Tim Berners-Lee is. And the answer is you may not, but you probably should, because Tim was actually the inventor of the World Wide Web. Back in 1990, he was the first to publish a website, and by 91, the World Wide Web was up and running. And what Tim Berners-Lee really did not intend on doing was disrupting many of the things that he actually disrupted, including but not limited to the way we read books and our news and our stocks, as well as the way we get our music or our videos, or even the way we date. These are all things he never intended to disrupt with the World Wide Web, but clearly we have disrupted it. What was more interesting is that Tim Berners-Lee was actually a scientist, a computer scientist to be exact, from England, and he was a researcher. And I think the main intention initially was to disrupt the way that we share medical literature, which is interesting because really it's the last thing that it's been unable to disrupt. That said, I think it's extremely important to embrace it today so that our future physicians and our future surgeons will have a better digital media of which to educate each other and their patients. And if you've followed this trend over the last 10 years, it's been very obvious how embracing it has been. So these are my 4 kids, actually, ages 6 through 13 in this photo, undoctored, but you can see they're all genuinely and heartfelt attached to their devices and using it not just to look things up, but to collaborate with their colleagues and their peers in real time. And if you have any children of your own, you'll know that online gaming is extremely important. Online communication, collaboration with each other, talking about the things that are important for that peer age-related conversation is nonstop, and it's happening on our mobile devices and on gaming devices like this. Here's an interesting statistic about a company that you may not have heard of called Roblox. Roblox is an online collaborating tool for younger kids. If you look at the left side of the screen, the average user age for Roblox is 15. They range from 6-year-olds to 18-year-olds. So this is definitely our youth. And what's most impressive is if you look at the current number of online users today, we are at over 150 million users as we are entering 2021, and this company just went public. So Roblox is growing. Our youth is collaborating online in huge numbers globally, huge. And the thing to remember is that this is the generation that's going to be our future surgeons and doctors. We are all familiar with the robotic companies that are out there. And what's beautiful about the robotic companies, especially Intuitive, is that they allow for ease of use in their technology. And so they can use advanced technology to take simple tasks like taking a yellow rubber band and placing it on a red peg, and then allow our youth to actually learn how to operate. This is actually my daughter when she was 7 years old, already very successful. And I can tell you that doing this with straight sticks was nowhere near as intuitive, if with no pun intended. So technology is keeping up with our children. You may remember that to be able to present our surgical education videos, we once had to put it on a VHS tape like this, submit it to a society, wait 3 months for them to look at them all, and then let us know we were going to be able to present. That's very different than today, when if you have a USB port, either a YouTube channel or a Facebook group or a LinkedIn and a smartphone, you can publish yourself. You can get your word out there, your technique out there, and start helping your colleagues and helping your patients. So education, what do surgeons like to do? If I can just bring this back to us. Well, we obviously love to operate. We would not be where we are today without it. But once we're done operating, we genuinely love to teach. And if it's not our immediate partners or our colleagues, it's other people in different lectures, students, residents, fellows, and fellow surgeons. And we do like to share this as wide as we can. And we share our educational abilities as wide as we can through current situations like conferences and hands-on labs, coaching and mentorship programs, and of course, publishing. But each of these has their limitations. Conferences are amazing because we get together, we get to socialize, but I can tell you that once we leave, a lot of us just go back home and go back into what we were doing traditionally without staying in touch with what we learned. So conferences have a limitation that we don't stay in touch afterward as often as we could. Plus, if you've been to conferences lately, especially towards the end of them, we are met with empty rooms. And there's nothing more disheartening than to a lecturer than to lecture to 4 or 5 people in a room when you were anticipating 100 or 200 people in a room. Hands-on labs are great. We can't learn new techniques without them. However, that requires people to travel, and for those of us who are teaching, to stay as a mentor. And some of us don't have mentors, so we don't know where to get these hands-on labs. So accessibility to mentors has been a challenge. Plus, as we travel and we leave our home, our children or our spouses may be upset that we're always on the road. Those of us who have been teaching for a decade or so can know that there's real life family impact when you're on the road many times a year. Finally, publications. This seems to be the main way that we are always going to keep in touch with each other and document our work. Nothing's going to disrupt this. It's been in place since the early 70s, and the adage, publish or perish, has been extremely important. And that if you don't publish your work in the National Library of Publications, that you probably didn't do it. You can't claim your territory. I challenge that to say that in today's age, we can choose any number of online digital platforms to actually publish our work where it can remain for almost as long and give us just as much relevance. In my line of work, I have embraced Facebook as the platform of choice, mainly because of its widespread, accessible, and obtainable methods of getting it. It's in every country, in every smartphone, and it's pretty familiar. At least when we started, everyone was using it for keeping in touch with friends and family, and it's migrated into, for at least me, a place where only I use it for work and not for social things. It turns out that 54% of patients actually are very comfortable with their providers seeking advice from online communities to better treat conditions. And so we're seeing acceptance of our patients, allowing us to use it for places that we get our advice. And then 60% of social media users, that like me and you, are more likely to trust posts and activity by doctors over that of any other group. And that is true. When you see colleagues with names that you recognize post things, there tends to be immediate credibility for the most part. And that actually, in many situations, will outweigh the credibility of even a publication. So if you see our colleagues doing something that resonates with you, that feels right to you, that you think is good for your patients, even if there's a publication saying the opposite, you're going to tend to migrate towards the advice of your colleagues that you trust online. Very interesting fact. So Facebook groups, which is not the same as a Facebook page, not the same as your regular social media posts. A group is a private area that you can only get into when you're allowed into it. So it's very private. And I found these in about a decade ago. And in 2012, December 13th, so we're going on 9 years now, I set up a group. I called it the International Hernia Collaboration, and we started and off we went with 9 surgeons collaborating about groin pain. And just by clicking the word create. I really didn't have any intention of it. For those of you that have heard of the International Hernia Collaboration, you know that it's grown. That was never our intention. It just happened because people that were using it found value on the site and kept going back to it. There was no promotion of the site. We didn't go out and try to sell membership. It just happened. And why did it happen? Because for the first time, the old way that we used to obtain data through online resources suddenly became that we could get it from each other. And that really had something that resonated with surgeons over time, where this ability to collaborate over a single case or collaborate over a CAT scan, collaborate over a treatment method, or even just hash out what a publication was about. Was brand new. And for the first time, we had this concept of obtaining consensus on the way to treat a disease state, as opposed to just one advice of a paper or a person. And so You all know that the way we want to treat a hernia in a 30-year-old skinny female or an elderly obese male or a kidney transplant immunocompromised patient will vary amongst users, and you'll get options A, B, and C. And the important thing here is to take the consensus of those different options and then see what you want to do best for your patient. And the process works very simply. Similar to a publication, you upload your case. It's basically peer reviewed by a bunch of colleagues, and then you come to a consensus as a final part of the thread. And the way that looks for those that don't know, for example, here's Dr. Carden asking for advice on how to manage a recurrent incisional hernia. He posts a CT scan. And of course, you know, traditionally we would go ahead and just figure out how to do this ourselves. But in the modern day world, we can get 51 comments in over the first 2 days from our colleagues. And not only that, our colleagues can be from around the globe, not just our state or our hospital. So now all of a sudden you're getting credible, real feedback on your case, not just from a paper that you read, but from people who've seen it, done it, who can help you through the actual operation themselves. And there's nothing more reassuring than bouncing what you thought you were going to do off of some more colleagues. So I just decided to look on the International Hernia Collaboration today just to see what came up. And this is some real-time stuff that's happening actually today. In May 2021, you can see that there's a CAT scan with a question of whether or not that's a recurrent inguinal hernia or a seroma. There's a post an hour ago about chronic pain that would happen after a varicocelectomy. Here's one from my friend Hugh in Australia that came in a few hours ago. He was looking for a diagnosis on a certain condition that he couldn't figure out after multiple imaging studies. And I was able to chime in, ask a few questions, and help him come to a diagnosis of anterior cutaneous nerve entrapment syndrome. And so here I am in New York helping a patient in Australia on a random Monday. So it's kind of cool to be able to do things like that. I don't know much else out there that's like that. As these posts fill up and populate and become part of the past, it's called user-generated content. User-generated content is stuff that we create ourselves together, and it turns out it's very, very popular. In fact, 35% of user-generated content is more memorable than other media, and 50% more trusted than other media. So we are on the right track with the social media created surgical education content. In modern day world online, we are teaching through video. Now, there's no question that the videos that are being published are amazing and we can learn from it. We're teaching through collaboration with our industry partners. Again, companies like BD have embraced this technology. Here's a live question and answer session that we did with Dr. Orenstein and Bard BD. That was about a month ago. And what's nice for these companies as well as that we can give them insights as to how that video went. So here's a 45-minute lecture that we put up, and we can see that it reached almost 4,000 surgeons across the globe, and the video was viewed almost 2,000 times. So that's not bad for a small group of, I guess we're approaching about 11,000 people now. What's even more interesting to me is that now all these groups are searchable. So you can go on there with your case or your question and actually look up threads from 8-9 years ago, 4 years ago, and get really good answers and advice and keep the threads going. I mean, all these threads are live, so they're not static. You can actually contribute to them in real time. Our group now is seeing about 220 posts a month. Over the past life of the group, that's over 16,000 peer-reviewed cases. We're global. We're in about 99 countries. The top 3 countries remain the United States, India, and Mexico, with Colombia, Brazil, and Australia right behind them. And we keep track of the comments, reactions, and views of these posts. This is the new way to judge reach. And I think it's very important to look at view count moving forward. It really will represent impact as we go ahead. It's taken a while, but the societies have caught on. SAGES actively uses 8 different groups that we help them start. The Colorectal Society uses groups now. The Hernia Society uses groups now. Pediatrics. Truthfully, I think we're in everything. We're in oncology now, vascular surgery, you name it, it's out there. And so it's really exciting to see the movement continue. As far as specialties are concerned, we've seen many different bariatric groups grow. My favorite is Tom Rogala's International bariatric club with Harris Qualja now running it. We've got oral maxillofacial surgery, high-tech surgeries, journal clubs, you name it. There's a whole bunch of them, including the robotic surgical collaboration, which is a tremendous success and an offshoot of the IHC Friends from early in 2015. The other thing I like about this for most surgeons is if you're on it, you actually can increase your referral base as you become more credible on the sites. More people actually send you patients as patients look for people in your neighborhood. We've been able to demonstrate the ability to get CME credits through groups and some of the activities that are being used there. So all the time that you spend online is not for naught. So I believe while we started off as a publish or perish nation, we're now into a post or perish nation. This is a phrase that has been trademarked by a law firm, but I love using it in this realm because I do think that if you can post your video, post your opinion, you will remain very, very active. There are papers that have studied our group. This is one done by the Hernia Working Group. It was led by the primary investigator, Mike Liang, and they found that our social media groups like the IHC can be a useful method to communicate challenging problems and important surgical educational tools. SAGES also published a white paper promoting the use of closed Facebook groups for this exact use and endorsing our group specifically. And of course, I really believe that the main thing here is if we connect all of you, all the doctors, then you connect the patients to better outcomes. And by connecting the patients to better outcomes, that's the name of the game here, for sure. The next step in this is to take the data that is being collected behind the scenes. The scroll above you is basically just a demonstration of all the data that can be collected from all the posts and all the comments that are made, and then figure out a new way to get information, not just back to the doctors and to the patients, but also to the industry and also to the hospitals about the optimized outcomes. And I think that's really the next step. It's where Facebook falls short because we can't use the data on the back end to do that, but I think there's definitely potential as we move forward. And taking all that user-generated content that's now out there and figure out new things that we can do with it, like disseminating and educating, discussing, mentoring, and publishing specifically. And I do think publishing is the next great frontier for our ability to collaborate. I want to thank Bard BD again for the opportunity to present to you. I hope I stayed on time. My final conclusions are that the next generation of surgeons will require a version of social media dedicated to collaborative learning and publication. So I think that that's really important. I think the IHC and the entire Facebook group or closed group movement has proven feasibility and that clinical posts can be a publication to those engaged, and all that together will enhance patient outcomes. I do think some of these threads eventually need to get published into PubMed to really increase its dissemination, but that's for another talk. So again, thank you very much. I'm Brian Jacob in New York City. I look forward to seeing you online in the IHC or another one of your favorite groups that are out there. As you know, there's a European group now. There's several in India, New Zealand, Australia, and around the globe. Thank you very much.
Great talk from Dr. Jacobs, and also from the BD side, I can just say that we're also going in this direction to make more digital and provide more professional education online. And as you can see here, Hernia U is already online for a while. So we are following this trend and want to support there. We're staying in the US. We're having Dr. Ross now from the University of Kentucky Medical Center. And René, what is his topic?
His topic will be optimization of complex abdominal wall repair outcomes. So we are very keen to hear Scott talking about this topic.
Let's see.
Hi, it's a pleasure to be here with you today to discuss optimization of complex abdominal wall reconstruction outcomes. I want to start by thanking both Becton Dickinson and the moderators for the opportunity to be with you today to discuss my opinions and approaches. In brief, I want to discuss and define the concept of complexity in abdominal wall reconstruction. We want to consider the potential benefit of precision medicine in hernia care, review the published outcomes following complex abdominal wall reconstruction, and ultimately understand the strategies to improve outcomes in complex abdominal wall reconstruction. There are many factors that go into deciding whether an abdominal wall reconstruction is complex or whether it's simply a hernia. Obviously, there's patient factors, and they may include the comorbidities, whether they're diabetic, a smoker, hypertensive. There are hernia characteristics such as the size, shape, configuration, the CDC wound class, the ventral hernia working group grade, the status of the patient from the standpoint of prehabilitation. Have they been optimized? Are they ambulatory or not? And then obviously there's the operative factors such as the technique and the experience of the individual surgeon, which has a major impact upon the outcomes for the operations which are being performed. Whether or not the patient receives appropriate perioperative care through an enhanced recovery protocol or not, and ultimately mesh. And I think all of these factors need to be carefully considered when evaluating a patient for a complex abdominal wall reconstruction, because each of these has an impact upon the ultimate outcome that we'll see for these patients. So precision medicine is an emerging approach for disease treatment and prevention, which accounts for individual variability in genetics, environment, and lifestyle. And it ultimately predicts which treatments will work in which individual groups. And I would tell you from the standpoint of hernia, we really have not adopted precision medicine to the degree that we've seen in oncology and some of the other medical specialties. And I think there's a tremendous opportunity that we'll get into in just a minute or two to truly identify which patients benefit from which types of approaches and which techniques. Because right now, many of us perform a one-size-fits-all type of hernia repair because of the evidence and the way it's evolved over the past several decades. So when we think about precision hernia care, maybe there's an opportunity to understand which patients would benefit from a suture repair alone. We can understand which patients benefit from minimally invasive or open procedures, and then look at mesh position. There certainly could be patients where an onlay is preferable to a sublay versus an intraperitoneal underlay. And then how do we fix the mesh? Is it suture, glues, tacks, or no fixation whatsoever? The mesh type, I think, is very important. Synthetic mesh is widely available and relatively inexpensive, but there may be some patient populations that benefit from absorbable meshes or biologic meshes. And why is that? Maybe there's a genetic predisposition in some of these individuals that allows them to respond better to one type of material versus another. And then obviously patient factors such as comorbidities will also impact the ultimate outcome that we see in many of these patients. So I want to start by talking about Lewandike's data published initially in 1999 and later in 2004. This prospective randomized trial really was the genesis of the concept that all patients benefit from a synthetic mesh. In this randomized trial, patients either received a Prolene hernia repair as an onlay with relatively small 2 centimeter margins of overlap versus a sutured-based technique. And in this study, over a long-term follow-up, they demonstrated a recurrence rate nearly of 63% with suture and 32% with mesh. And this really was the genesis of the concept that incisional hernia repairs should all be repaired with mesh. And from this study, as a general rule, synthetic mesh is widely utilized on a routine basis for the repair of incisional hernia. I'd like to challenge you to think about this study in a little bit different manner by keeping in mind the fact that 37% of the suture-based repairs were successful, and the mesh repair success rate was only 68%. So I think there is an opportunity to do things a little bit better, and I think it really challenges the question as to whether or not synthetic mesh is truly beneficial. We know from Kokotovic's data that mesh has complications, and we're gaining increasing awareness and familiarity related to this. And in the Danish hernia registry, you can see in open mesh hernia repair operations, there's about a 1% per year incidence of mesh-related complications. And in this report, 6% of patients had some form of mesh-related complications. And we know that reoperations likely underestimate the incidence of these complications, so there's probably a higher number than what we're actually seeing in this particular study. Now, we also know that comorbid conditions are a significant driver of postoperative outcomes. We know that when patients have surgical site infections and complications following their hernia repair, their likelihood of reoperation and reintervention increases, and the second hernia repair has a higher failure rate than the one prior. When we look at something as simple as comorbid conditions such as smoking, diabetes, and obesities, what you can see is that with each of these comorbid conditions in isolation, it increases the risk of surgical site occurrence in green, surgical site infection in blue, and surgical site occurrence with procedural intervention in orange significantly. But by the time you have three comorbid conditions, you can see there's 2.5-fold increase in the likelihood of having some of these complications. So these comorbid conditions are major drivers of postoperative poor outcomes. We know that patients who have clean contaminated and contaminated hernias have 2 and 3-fold higher likelihood of developing both superficial and deep surgical site infections. And although in this study we're unable to appreciate the incidence of mesh infection, we know that some of these patients are likely to develop complications such as mesh infection, which necessitates subsequent mesh removal. Although none of us planned for an enterotomy during our initial hernia operation, as you can see here in this study from the America's Hernia Society Quality Collaborative, over 5,000 hernia repairs with an incidence of enterotomy of approximately 2%, those enterotomies are major contributors to postoperative complications, with a 4-fold increase in surgical site infection, twice the reoperation rate, twice the readmission rate, and 3 times the rate of mortality. So in my opinion, there's no such thing as just a small enterotomy. Enterotomies are major events, and I believe they should be handled differently. And in my opinion, even the most straightforward of hernia with an intraoperative enterotomy changes its status to a complex hernia repair. Can we predict those patients who are going to require mesh explantation? In this study by Mike Lang and his group, he looked at the ventral hernia working group grade upon the long-term risk of having to remove the mesh. And as you can see here, in those patients with low-risk clean hernias, that risk is 1%. But by the time you get to a grade 4 hernia, patients that have active infection or septic dehiscence, you can see the likelihood of having a mesh infection requiring mesh explantation approaches 1 in 6. And the challenge is mesh complications are not only problematic for our patient, but they're extremely expensive. This study out of the University of Kentucky looked at ventral hernia repairs and the impact on infections on cost. And you can see while the average ventral hernia repair costs about $11,000, a wound occurrence nearly triples the cost of that ventral hernia repair in the inpatient setting, and it adds significant costs in the range of thousands of dollars to the postoperative care. In the presence of every difficulty lies opportunity, and I will tell you, in the setting of value-based medicine and cost awareness in the realm of surgical care, P4HB provides a unique opportunity to reduce the incidence of complications and the cost associated with the management of surgical site infections in ventral hernia repairs. Back in 2013, I had the opportunity to perform a pilot study evaluating P4HB hernia repairs. In this initial pilot study of 31 patients that were followed for 2 years with clinical evaluation, we found that we were able to successfully repair all 31 patients. And with that median follow-up of only 2 years, none of those patients ever developed a hernia recurrence. John Fisher's group recently reported on 70 patients that underwent ventral hernia repair utilizing P4HB, and this is a fairly complex group of patients with CDC classes of 1, 2, and 3, with hernia defects of over 300 square centimeters, with a hernia width of 17 square centimeters, implanting meshes nearly 500 square centimeters in size. And he found with a median follow-up of approximately 2 years, his hernia recurrence rate was only 6%. Joe Buell, who's now in Asheville, North Carolina, previously at Tulane University in Louisiana, recently reported upon his long-term outcomes utilizing P4HB as an onlay in ventral hernia repair. In this study, he evaluated these long-term outcomes in a group of 31 patients who underwent phase hernia repair and compared them to a group of consecutive porcine acellular dermal matrix hernia repairs immediately preceding to these 31 patients. These groups were fairly well matched from the standpoint of comorbid conditions and hernia characteristics, with the exception of the size of the P4HB hernias were a little bit wider, and the median follow-up in the P4H group was actually a little bit longer. And what he actually was able to demonstrate in this Kaplan-Meier analysis is that the incidence of hernia recurrence was less in those patients undergoing P4HB repairs as an onlay as compared to those patients that underwent repair with a porcine acellular dermal matrix. I want to spend a little bit of time talking about the outcomes that we've seen in our prospective observational study of P4HB mesh. This study that was conducted across 16 sites throughout the United States with a 60-month follow-up where patients were enrolled beginning in October of 2013 and extending out through January of 2015. Now, important to understand is the inclusion criteria. These were all CDC class 1 hernias. Surgeons were able to place the mesh either as an onlay or as a pre-peritoneal repair. And the patients had to have at least one high-risk criteria as defined below, whether it be BMI, smoking, COPD, diabetes, or some of these others listed. Now, there were some notable exclusions in which the patients could not have had 4 or more prior repairs. BMI greater than 40 was excluded, as well as American Society of Anesthesiology class 4 or 5. Additionally, all of these patients had to undergo repair as a reinforcement. Bridged repairs were excluded. You can see here in this study about 3/4 of the patients underwent a retrorectus or pre-peritoneal repair, approximately half of those without a component separation. The other half were straightforward Reeves Stopa repairs, whereas the onlay repairs were largely performed without any form of component separation. When we looked at the primary endpoint of recurrence at 18 months, you can see the recurrence rate was 9%. Keeping in mind that 3/4 of the patients were retrorectus, what you can see here is that the retrorectus recurrence rate at 18 months was 6%, whereas the onlay recurrence rate was 18%. Surgical site infection rate was approximately 9%, and that did not change following 6 months after the operation. Now, this past year, we published 3-year outcomes using a Kaplan-Meier analysis with 82 patients undergoing follow-up at the 3-year time point. The recurrence rate was approximately 18%. Again, surgical site infection rate did not change following the 6-month time point. And I also want to highlight here is that there were no infected mesh removals throughout the duration of this study, as seen here in the gray line, where all surgical site events occurred early on within the first 30 days, and there were no long-term mesh complications or mesh erosions. Recurrence rate has relatively plateaued out at the 3-year time frame. On sub-analysis, looking at hernia recurrences based upon location of the mesh, you can see here the retrorectus recurrence rate at 3 years is 13%, whereas the onlay recurrence rate is approximately 30%, which gives us the overall recurrence rate of approximately 18%. Now, I will tell you, and I can't share it with you today, the prospective 5-year outcome should be reported in the fall of this year, and we're looking forward to sharing them with us at an upcoming meeting, hopefully in September. Others have reported successful outcomes using P4HB or Phasix as an onlay. This study by Jason Spector and this group out of Columbia University in New York City demonstrated successful repairs with a recurrence rate of approximately 17%. So again, I think an onlay repair in general tends to have a higher recurrence rate than a retrorectus repair. I think utilizing the appropriate technique, you can expect to have fairly reasonable outcomes utilizing an onlay approach with a P4HB mesh. So I think it's an interesting discussion to have is how good does a mesh need to be relative to a synthetic mesh for it to be adopted as a standard. When we look at the data and the published literature for 3-year outcomes with ventral hernia repair, I want to tell you that there's a paucity of literature. When we looked at the 3-year study initially published by Lewandijk back in 1999, the 3-year recurrence rate for synthetic mesh was approximately 23%. When we look at the Danish Hernia Registry of reoperation rate for ventral hernia repair in Denmark, you can see there's approximately a 10% 3-year reoperation rate, which we know significantly underestimates the incidence of hernia recurrence, but I think it serves as a benchmark to evaluate the success for a synthetic-based hernia repair. So I think having recurrences around the 20% or less certainly is consistent with what we see with synthetic mesh hernia repairs. I think it's also important to keep in mind that balance between infection and hernia recurrence. As we have absorbable meshes, I typically felt that an absorbable mesh would have a lower incidence of infection with the trade-off of a higher risk of hernia recurrence. I will tell you that's not how I currently feel. I generally feel that for the appropriately selected patients, we can expect to have recurrence rates comparable to what we see with synthetic mesh without that risk of having to have a mesh removed in high-risk patients. In fact, looking at our database in this unpublished series as of this present time, we looked at our first 100 absorbable mesh placements compared to a group of synthetic meshes placed over the same period of time. And I will tell you the complexity of the absorbable meshes was greater than that of the synthetic group. But what we were able to demonstrate is that the recurrence rate between the groups, 8% versus 9%, was statistically no different between synthetic and absorbable meshes. So I really do believe that we can achieve recurrence rates comparable to synthetic mesh using an absorbable material when utilizing the appropriate techniques. And what are those appropriate techniques? Well, in my hands, that consists of a preperitoneal approach. My most common approach is going to be a Reeves stopa with a dissection of the posterior rectus sheath from the rectus abdominis complex, dissection of that posterior sheath out to the lateral aspect of the rectus muscle with separation of the epigastric vessels from that posterior rectus sheath and careful dissection to preserve that neurovascular bundle to the rectus complex while also minimizing skin flaps because those perforating vessels from the epigastrics, which are penetrating through the rectus abdominis muscle, are ultimately going to supply the blood to the superficial skin overlying the lower abdominal wall. Now, as we dissect out to the lateral aspect of the rectus complex, we'll see the neurovascular bundles, which are innervating the rectus abdominis muscle, and we're going to preserve them when doing a Reeves stopa type hernia repair. Now, in circumstances in which I'm not able to close the fascia with a Reeves stopa repair alone, I will proceed with a transversus abdominis release. As demonstrated in this cartoon, we will divide the posterior rectus sheath, including both the posterior lamella of the internal oblique as well as the transversus abdominis muscle fibers, typically beginning at the costal margin, extending down to the arcuate line, medial to those neurovascular bundles. And once we're in that space, we're then able to widely separate the transversalis fascia from the overlying transversus abdominis muscle and create a large pocket for a piece of mesh. And as you can see here in this cadaver on the left-hand side of your screen, you can see the rectus muscle has been separated and we're dividing those robust muscular fibers of the transversus abdominis medial to those neurovascular bundles. Now, once we've completed that dissection, we've created a wide pocket that allows placement for a large mesh. The neurovascular bundles to the rectus abdominis muscle have all been preserved as they run between the transversus and the internal oblique muscle. Superiorly, we're able to completely disconnect the transversus abdominis fibers as they insert onto the costal margin. As we proceed cephalad, we're actually taking the peritoneum off the undersurface of the diaphragm, and here demonstrated above the xiphoid process is the central tendon of the diaphragm. So these transversus abdominis release procedures allow for wide dissection well up above the costal margin and behind the xiphoid process for placement of large synthetic meshes. And in this particular situation, you can see here placing a large 30 by 30 centimeter mesh. In some circumstances, we're able to place even larger meshes into that preperitoneum. In this particular picture, you can see here we are unable to close the posterior sheath, so I placed a bridging mesh to reconstruct the posterior sheath prior to placing my definitive hernia mesh, and this allowed me to place my mesh extraperitoneal as opposed to placing it as an intraperitoneal graft. In some circumstances, I will be able to stay totally extraperitoneal. This is a patient who had a large primary ventral hernia, or essentially an umbilical hernia that was present for over 30 years. We were able to do this with a completely extraperitoneal dissection, ultimately reduce the contents into the peritoneal cavity and simply imbricate the hernia sac and place our mesh. And in doing so, we're able to avoid the need for adhesiolysis, minimize our risk for enterotomy, and place our mesh and close the defect. Now, it does create a little bit of a unusual appearance on an early postoperative CT scan, where you can see the involuted hernia sac. Now, this was a massive hernia, so you can see the large inverted peritoneum of that fatty hernia sac, but in most situations, this is much more modest. So I do demonstrate that just so you can appreciate the appearance in the event of a CT scan. This is another example of a complex hernia with a patient with a multiply recurrent hernia with trophic changes of the overlying skin. He actually needed his gallbladder removed concomitantly as well. On the right, you can see we did a completely extraperitoneal dissection of his abdominal wall with the rectus muscle elevated, the transversus abdominis muscular fibers divided. I tend to do this as a routine, and then following completion of our hernia dissection, then I entered the peritoneal cavity, resected the prior mesh, resected that abdominal wall skin, and removed his gallbladder. And as you can see here, we're able to place a large piece of mesh in the pre-peritoneal space and ultimately close his fascia primarily. And this is him in the hospital immediately prior to discharge, and this is him 12 months following his operation with a successful hernia repair. So I just want to sum up by saying I think there's many factors associated with complex abdominal wall reconstruction outcomes. Optimization, appropriate techniques, and mesh selection are essential. Bioabsorbable mesh hernia repair is an alternative to synthetic mesh when permanent mesh is not desired or needed. But I do think there is an opportunity for the utilization of precision medicine in hernia repair, with future studies identifying the most appropriate patient populations for each of these techniques. Again, I want to thank the Phasix research team, 16 sites around the country. We couldn't have done this research without them. And I want to thank you for the opportunity to be with you today. Again, many thanks.
Thank you, Dr. Ross, for this very interesting presentation. We're now coming back to Europe. Our next speaker is coming from Spain, Dr. Bueno, member of the Unit of Abdominal Wall Surgery in La Fe University in Valencia. And René, just tell us, what is his topic?
Yeah, the topic will be chronic mesh infection. What do we do? So we can start with the next very interesting lecture.
Good afternoon and hello to all hernia friends, and thanks to BD for your kind invitation. It's a pleasure to be in this session. I'm gonna talk about complex abdominal wall repair, especially in cases of mesh infection, a wide and complex topic in hernia repair. These are my disclosures. As you know, mesh infection is cause of significant patient morbidity and increases costs for the healthcare system. Mesh infection represents one of the most devastating complications in hernia repair. Incidence is about 4% in this surgery because to say biofilm is to say resistance. Bacteria are 1,000 times more resistant due to the plasmid transfer in situation of immunocompromised patient. Biofilm keeps the chronicity of infection, and this fact may explain the finding of new reinfection after 4 or 5 years from the abdominal wall hernia repair. These are the most significant risk factors related to the patient: obesity, smokers, diabetic, etc. are more likely to have a surgical site occurrences or mesh infection compared to healthy people. Regarding the surgical technique, we can find a lower incidence in laparoscopy repair versus open repair. Also, in case of incisional hernia, the incidence reaches up to 8% in comparison with growing hernias that is approximately 1%. So the factors related to the procedure are open repair, as we've previously commented, the suprafacial location of the mesh, concomitant surgeries of digestive tract like enterotomies, and finally surgical site infection. And why? Because it has been reported that around 18% of surgical wounds can develop a biofilm. As you know, the main organisms found in the mesh infection are Staphylococcus, especially subtype aureus, and methicillin resistant. Regarding the mesh factors, we have macroporous and microporous prostheses. The management of infection will be different in one or another case. As you know, defensive cells can reach the infection site depending on the size of pores, preventing a bacterial growth in cases of bigger pores, or not being able to neutralize the germs in meshes with smaller pores. Therefore, an initial conservative treatment, for example, negative pressure therapy, or trying a partial mesh removal, can be done in cases of PPL mesh. Another interesting question is, can we give a chance to salvage the infected mesh? It depends on patient status, comorbidity, type of mesh, type of germen. It's also interesting to remark that the spontaneous resolution of some infected meshes may reach up to 15% during the first year of the chronic mesh infection in different situations, but always considering the importance of these previous factors. Conservative treatment options would be CT or ultrasonographic or surgical drainage debridement to solve the collections due to the biofilm, or a deep cleaning in the mesh area can be performed with a powerful bound debridement system and surgical debridement, or finally negative pressure therapy for trying to salvage the infected mesh. This is an interesting algorithm of colleagues from Carolina Medical Center, led by Dr. Hanniford. In cases of lightweight PPL mesh, we can initially pose the possibility of not excision. In cases of methicillin-resistant staphylococcus, this option is not possible, needing the exploitation in all cases. And finally, PTFE or multifilament polyester prostheses should also be removed or explanted. According to the need of explantation and the following an abdominal wall reconstruction, we have one-stage versus two-stage management. On the one hand, one stage represents the most desirable option and more comfortable for the patient, but we have to remark and define the role of the prosthesis, because the placement of a new mesh simultaneously with the infective prosthesis implantation has not been universally accepted. There is a high possibility of mesh reinfection even with biological scaffolds or permanent synthetic meshes. Consequently, a two-stage management has been recommended as the ideal approach, although causes longer hospital stay and less comfortable for the patient with chronic mesh infection. It's also more expensive to the one-stage treatment because of two surgeries of two admissions, and in this the first time, hernia recurrence can appear up to 75% of patients. In my opinion, biologicals have been a deception in this field. This conclusion can be demonstrated in several reviews and meta-analyses published last 2 or 3 years, like this one, although they're associated with a lower rate of mesh infection and are less likely to require mesh excision than synthetic meshes. Its high recurrence rate up to 30% and the development on surgical site occurrences has caused a change in perspective of management of repairs and their contaminated fields, especially in grade 4. As you know, phases is a fully resorbable monofilament polydroxybutyrate mesh. It's polymer which is produced by Escherichia coli bacteria, has high flexibility and tensile strength for tissue remodeling. It has also been achieved higher rates of bacterial clearance with a more minimal effect on heat strength because of the full reabsorption and reduces foreign body reaction. These are the most important studies about phases mesh in terms of hernia repair and several grades of contamination. The most frequent series report situations with contaminated fields grade 1 and grade 2. Mainly the first publications about phases. Later we can find racing papers about grade 3 and 4. Global results saw an acceptable behavior of these prostheses, especially in retromuscular location, with rates of cervical site occurrences around 10 to 24%, or even hernia recurrence mostly lower than 7%. Only one paper, Warren et al., not so good results are reported in these terms. Our group shows the only one study about grade 4 in single stage management of chronic mesh infection with phases mesh. I'll see you later. Therefore, more prospective studies are needed to clarify main indication of these absorbable meshes with more homogeneous data, reporting a longer postoperative follow-up with the purpose of the goal of analyzing the possibility of replacing biological meshes with these biosynthetic scaffolds, mainly in cases of contaminated fields grade 4, but currently this asseveration has not been clearly confirmed yet. But why could phases mesh be useful? We can find pros and cons. For example, pros as reabsorption after 18 months with a foreign body removal or a resistance to infection in vitro. But drawbacks of these meshes revolves around the significantly higher expense than synthetic mesh and the possibility of recurrence when the scaffold has disappeared, roughly after 12 to 18 months. Finally, one study reported 3 cases of phases mesh reinfection, and they had to plan them for resolving for the episode. Therefore, there isn't an unified attitude or a strong asseveration about this use. To try to report our experience with phases mesh in case of grade 4, the main goal of our study was to report the results about the efficacy of one-stage treatment of the chronic mesh infection after abdominal wall hernia repair with infected prosthesis excision and simultaneous replacement with these biosynthetics absorbable mesh. Therefore, 30 patients with mesh infection and period of a study of 3 years, analysis of main parameters of our study, was recurrence, mesh reinfection rates, and surgical site occurrences during the study. I'm gonna show you several videos about some cases of Aarhus area. This one is a preperitoneal infective mesh that we have to explant. The dissection in this area can be so difficult that it's possible to injure some small bowel loop. All depends on the strength of the adhesions with the mesh and intra-abdominal content. And the solution was to replace the preperitoneal mesh by a phasis scaffold through a retromuscular repair after closing posterior seat. This patient didn't need any abdominal wall reconstruction because there isn't any hernia defect. Only we performed the mesh replacement. The second case is an only infected mesh after umbilical hernia repair. As you can see, we use methylene blue through the cutaneous fistula of the biofilm to mark its location. The only mesh explantation is pretty easy than preperitoneal or intraperitoneal removal due to a have clear dissection plane, and the probability of injuries is lower. We like using a powerful wound debridement system that by suctioning and irrigation with a physiological saline solution, local antibiotic irrigation and antiseptic solution were not usually applied prior to absorbable mesh placement. This is another patient with a mesh infection after anterior component separation, and we explore the cutaneous fistula and we try the complete explantation of PPL prosthesis. I say I try because the complete excision sometimes is complicated with the big area that the mesh involves. Usually its size is 40 by 40 centimeters, and some undetected rest may be left. In this case, we remade the component separation with a phasis mesh, and this is the final result. CT scan is useful and I think mandatory to identify the collected infected mesh, and it's possible association with some hernia defect like in this patient. He has a midline incisional hernia after abdominoperineal resection for rectal cancer 6 years ago, and preperitoneal hernia repair with a PTA fee for umbilical hernia some years later. And you can see the complete mesh extrusion like a birth, straightening or taking out the PTA fee mesh. Later, we performed the hernia repair and the phasis scaffold placement. Results, PPL was the most frequent removed mesh. Need of abdominal wall reconstruction was needed in 18 cases, approximately 60%. A surgical site occurrences rate of 25%, mainly seroma, hematoma, and bound infection. And remember the context of dirty surgery and its high probability for developing complications related to surgical bound. And finally, no prosthesis reinfection and 2 patients with hernia recurrence. We wanted to compare in a second step our results with the patient that we have previously applied a 2-stage approach with a permanent synthetic mesh several years ago. And you can see 1 stage, 30 patients versus 2-stage management in 41 cases. And I want to remark a longer average duration of surgery and length of stay due to the 2 procedures. hernia recurrence rate was similar in both groups, and higher rate global complication and surgical site occurrences in two-stage group. And finally, no differences in prosthesis reinfection. Therefore, as final comments, the chronic mesh infection is a serious complication after abdominal wall hernia repair. And we have a positive experience with phases scaffold in chronic mesh infection with a low hernia recurrence rate and no reinfection. Phases mesh is in single-stage management versus two-stage treatment in prosthesis infection is safe, and more prospective studies are needed comparing biosynthetic and permanent synthetic meshes, especially in CDC grade 4. Thank you for your attention.
Thank you, Dr. Bueno, for sharing your expertise there. And we're now moving on to Ireland. We have Dr. Oglesby here from the NHS Bayside Hospital in Dundee. Let's have a look what he has to say. René, share with us his title.
Yeah, this is really a hot topic. Botox, the new gold standard.
Good evening, everyone. My name is Stuart Oglesby. I'm a consultant surgeon working in the city of Dundee in Scotland. I'd like to thank BD and the team for asking me to talk this evening about botulinum toxin and whether this should be considered the new gold standard in abdominal wall repair surgery. The first question to ask is, what do we mean by Botox? Well, botulinum toxin A is one of a number of different types of botulinum toxin produced by several different organisms. Only botulinum toxin A has been used for abdominal wall repair. None of the other toxins have been used. It works by inhibiting acetylcholine release at the neuromuscular junction and has approximately 4 months duration. Even within botulinum toxin A, there are a number of different subgroups as listed here. And this is important because all of these potentially could be used in abdominal wall repair, and all of them need to be used at different doses. We don't mean botulinum toxin B. Botulinum toxin B is used in some medical applications, but hasn't been reported in abdominal wall repair. Looking at what's available in the United Kingdom, there are a number of different preparations available. Botox, in fact, is actually a trade name of the Allergan product and is Ona botulinum toxin A. The other trade names and other products contain different types of botulinum toxin A. So what is the problem we're trying to address? Well, the problem is here really. This is a fairly well-known paper and demonstrates what most of us believe, which is that fascial closure is associated with a lower hernia recurrence rate. Bridge repairs, on the other hand, are associated with a higher incidence of recurrence, and botulinum toxin, it is hoped, will enable fascial closure to reduce our recurrence rate. It is, however, worth saying that some groups have excellent results without fascial closure, particularly the groups in Edinburgh and Malmö. The other technique for achieving fascial closure is component separation, and as we all know, this is not a trivial undertaking, and some variations of component separation are associated with a fairly high risk of wound morbidity. So here is the other problem. This is loss of domain. The oblique muscles have retracted laterally, and there's a reduction in the abdominal cavity volume. Again, it's hoped that by applying botulinum toxin preoperatively, the abdominal cavity volume will expand. I need to acknowledge that this image is taken from the review paper shown there. And this is actually one of 3 different review papers that are worth referencing because they provide a good summary of the current evidence base. Particularly the first paper is very recent and provides an up-to-date summary of botulinum toxin A practice in abdominal wall repair. The first thing to say from all of these reviews is that botulinum toxin is actually very safe to use. It's got a very low risk of significant complications, and there isn't very much else we do in abdominal wall surgery that is low risk. The results in these studies also show that fascial closure is enhanced with the use of botulinum toxin and allows closure in circumstances where this may not be possible, with limited wound morbidity. It is also worth saying that botulinum toxin use in abdominal wall repair is an off-license use. So what are the reported techniques? Well, there's quite a heterogeneous list of techniques, various groups using different numbers of injections, different ways of targeting the muscles, and a different dose of botulinum toxin A. So most of the studies that have reported the use of ONA botulinum toxin A or Botox Allergan product report 200 to 300 units per application, with 100 units each side or 150 units each side, depending on the dose. Those papers that have used Dysport or ABO botulinum toxin A use 500 units of the product, 250 units per side. Most studies use 3 to 5 injections per side and are image guided, usually with ultrasound, but there have been some reports using CT and EMG to help localization. One paper reports only 1 injection per side, but this is a kind of a rarity, I think, and most people would probably prefer to use at least 3 injections. The variability in timing of the injection exists, with some papers reporting use immediately preoperatively on the day of surgery. However, it does take Botox some time to work, and probably somewhere between 2 and 6 weeks preoperatively is the ideal injection time. So what do we see? What are the effects of botulinum toxin injection? Well, the average results from the majority of studies show a 2.5 to 4 centimeter elongation of the obliques on each side as measured by CT. And this corresponds to a reduction in 6 to 8 centimeter of the transverse defect width. I think most people who practice in this area would consider an 8 centimeter reduction in transverse defect width to be something worthwhile and a great help in our practice. Furthermore, some studies have reported an increase in abdominal cavity volume by up to 2,000 cc's, and this will obviously facilitate a return of the viscera to the abdominal cavity. Overall, the review papers have reported fascial closure rates well in excess of 90% and medium-term recurrence rates in the order of around 6%. So what is my practice? Well, I certainly would use botulinum toxin A injection for all defects with a transverse diameter of over 10 centimeters. If the defect is less than that and I'm anticipating difficulty with closure, if it's near to the xiphisternum or near to the pubis, I may inject botulinum toxin for smaller defects. I usually inject the botulinum toxin 3 to 6 weeks prior to repair, and I use Allergan botulinum toxin A, which is a branded product Botox. I use 200 units of Botox, 100 units each side, and that cost comes with an approximate cost of €300 or £300. I reconstitute the product in 20 mils of normal saline, and I draw it up into 10 syringes so that I can use 5 injections per side. I use ultrasound to target my injections. And the first thing I do is identify the landmarks for the ultrasound. The patient's head is at the top of this image with the costal margins indicated, and the anterior superior iliac spines towards the bottom of the image. The 2 parallel lines in the middle are the palpable hernia defect. So this is an ultrasound scan of the left side of the patient's abdomen, and the first thing we want to do when we do the survey is identify the muscles, the transversus abdominis, internal oblique, external oblique, the rectus abdominis, and the linea semilunaris. And the intention is to mark the abdominal wall with a pen to denote the edge of the rectus sheath at the linea semilunaris. So here is the image we see, and you can see that the external oblique, internal oblique, and transversus abdominis are fairly clearly identified. Towards the bottom of the image are the abdominal viscera, and you'll see peristalsis in there when I start the video. There's the peristalsis. There are the muscles moving with respiration. The next thing I want to do is come medially to try and identify the rectus abdominis and the linea semilunaris, which are indicated there with the arrows. And I then mark this with a pen, and you can see the pen imprints on the video. Once again, just to keep your eye in, this is what the oblique muscles look like, and these are the areas that we hope to inject in the next video. So once we've marked the edge of the linea semilunaris as indicated here, we need to identify the injection points. I simply do 5 injection points like so, spaced as evenly as I can, and then try and inject at those points under ultrasound control. So here is the familiar image with the ultrasound. What I don't try and do, because it takes longer, is actually to visualize the needle coming into the abdominal wall. What I look for is evidence that you can see the needle puncturing the muscles because the muscles move, and you then see a blush of liquid being injected into the muscles when you inject. And I hope that's clear on this video. So here is a needle coming in at the top of the screen, and there is the Botox being injected. And you can do 2 or 3 passes to make sure you get this perfectly injected. And that's the kind of image I'm looking for after I've injected the Botox. So that's the medial image right on the medial injection right on the linea semilunaris. I would repeat that 3 times along the semilunaris, and then 2 injections more laterally. So in summary, botulinum toxin A injection for abdominal wall repair is easy to perform. Unlike most of the interventions we undertake, it has a low risk of complications. It facilitates fascial closure and helps with loss of domain. There is a reduced risk of wound morbidity compared to component separation, and a reduced operative time compared to component separation. It also doesn't compromise the abdominal wall and does not prevent concurrent or future component separation. At €300 or £300, it comes with a reasonably acceptable cost. So I would argue with the information provided that botulinum toxin A injection is the current gold standard. Not very much else we do in abdominal wall repair has a similarly good risk and benefit ratio and helps enormously in abdominal wall repair. Thank you. I hope to answer any questions in the question session, and thank you for BD for asking me to talk.
Thank you very much, Stuart, for this nice presentation. And I have to correct myself. You're not in Ireland, you're in Scotland, just to make this correct. Now we're switching over. I'm very sure about this country. We're switching over to France, and we have Johan Renard with us. He is the associate professor at the University of Reims in France. And René, tell us what Johan will talk about today.
We will speak about the limits of the possibilities in complex abdominal wall reconstruction, especially loss of domain, grade 3 infected cases.
Hello, everybody. Would like to thank first BD Bard for their invitation for this symposium and for this opportunity to speak about the limits of the possibilities in complex abdominal wall repair, and in particular, the loss of domain and the infected cases. Indeed, complex cases means several possibilities, and today I want to speak first about the loss of domain, and after about the wound infection and the infected meshes. First, I would like to tell you what are my limits of possibilities concerning the loss of domain. You know, loss of domain consists in second abdomen, and the repair leads to subsequent difficulties, in particular the reintegration of herniated organs, the complete closure of the abdominal wall, and the risk of intra-abdominal hypertension that may lead sometimes to respiratory failure, and in particular the abdominal compartment syndrome. For this patient, in my unit in Reims, we used always the progressive pneumoperitoneum described by Goni Moreno in 1940, and we published our results in 2016, including 45 consecutive patients. Briefly, what are our results? We reported a rate of surgical site occurrence as high as 41%. Surgical site infection, 27%. And recurrence rate, 10%. These results are not so bad, but I think it is not so good results, and perhaps it is my limit of the surgical possibility. And the question is, how could these results be improved? The second condition I would like to use today to explain you my limits of possibilities are the infected condition. These complex cases are, in particular, the grade 3, according to the modified ventral hernia group classification, and in particular, the contaminated and dirty cases. This condition may lead to 46% of surgical site occurrence, and for these cases, actually, biologic meshes are always mandatory. And we use, in my unit, biologic meshes to treat this patient until 2016. Indeed, in the years 2010, we thought that these biologic meshes may be the ideal meshes to repair infected abdominal wall, and biologic were used around the world to treat these patients. But analyzing the literature, we know that the use of biologic meshes for grade 3 and 4, according to the old classification, that may lead to high surgical site infection rates, as high as 61% in some publications, and high recurrence rate until 40% in some publications. And according to recent reviews of literatures, for example, this one, we know that biologic meshes are not better than synthetic meshes, and they show considerable higher rates of surgical site complication and hernia recurrence rate until 30%. So we used in our unit from 2010 until 2016 biologic meshes, many types of biologic meshes for infected patients. And we published our results in 2018. We compared a group of vicryl mesh, 57 patients, so it is a two-step strategy because we know that using vicryl mesh, the patient will have a recurrence. And we compare with a second group using biologic meshes, including 24 patients. We used the Stratis mesh. What are our results? We reported a postoperative surgical site occurrence of 46%, a surgical site infection rate of 33%, and the recurrence rate after 18 months of follow-up of 16.7% compared with the 70% using the vicryl mesh. These results are not so bad, but they are not very, very good. And I think it is the limit of my surgical possibilities for these patients. So the question is, how could we improve these results? So we use the Phasix mesh for these patients, loss of domain and infected cases from 2016, because we know that biologic meshes have poor results with high costs. And we use the Phasix mesh for all our infected cases, for all our loss of domain cases, and we included all our patients in the French register from November 2016. Just some example, using the Phasix mesh on a grade 3 patient. He had an infected mesh, as you can see, and here are the perioperative photographs with the excision of the old infected mesh and the use of the Phasix mesh for this patient. Another example, with loss of domain now using the Phasix in an extraperitoneal position. This patient has median incisional hernia with loss of domain, and we use the Phasix mesh in a retrorectus layer, and you can see here the results. A third example, this patient with a loss of domain, subcostal incisional hernia, and we treat him with the Phasix mesh. A last example, it was a loss of domain with an infected mesh. On this patient, she had a multiple sclerosis, and we used the Phasix mesh in an extraperitoneal layer. So we are very satisfied from when we use the Phasix mesh for this patient. But what are our real results? First, concerning the infected cases, before the use of Phasix, we had a surgical site occurrence of 46%, and using Phasix on 23 patients, we had a 35% of surgical site occurrence. It is lesser, but not significant. The same for surgical site infection, a lesser rate using the Phasix mesh, but is not significant. And then a lesser recurrence rate, but not significant. The two patients before Phasix, so with biologic meshes and using Phasix, have the same baseline characteristics, the same technique, and the same follow-up. What about the loss of domain? We show the same results, so lesser or the same surgical site occurrence rate, lesser surgical site infection rate, and lesser recurrence rate, but is not significant, with two groups before using biologic or synthetic mesh and after using the Phasix mesh. So what can we say about these results? First, we think for these complicated patients, the technique is first essential. And we use always, whenever possible, a big piece of mesh in the retrorectus position according to Reeves repair, using a large piece of mesh, and we should always close the muscles, whatever the mesh we use. But these bad results using Phasix or using the old strategies are probably explained by this patient because they are very difficult to treat with high comorbidities, and pastors say that the germ is nothing, the comorbidities are all, and we agree with him. What is sure today is that we show here that using the Phasix mesh, we have the same results than the biologic one with lesser cost. And José published that he had a better results on infected cases using the Phasix mesh. So as a conclusion, before a good mesh, we should use a good technique and a good preparation. Actually, in Reims, we use only the Phasix mesh for the complex cases. It is our protocol, and all our Phasix mesh are included in the prospective study with 6 other French universities. Phasix mesh appear effective in case of infectious complication, and these good results should be confirmed in the long-term analysis. Thank you very much for your attention.
Thank you very much, Johan, for sharing your expertise from Reims. Very impressive data. And we have now the last 2 presentations coming up from Italy. And the first one is from Diego Cucurullo. He is from the Ospedale Monaldi in Napoli, Italy. And please, René, share with us what Diego will present today.
He will speak about different applications of robotic approach in abdominal wall surgery, a single center experience. So,
perfect. Let's go.
Diego, let's go.
I am honored to take part of the 2021 International Hernia Symposium. My lecture today will deal about our experience concerning robotic approach in abdominal wall surgery. This is my disclosure in the last 2 years. We started with the robotic surgery in 2002 with application on lower GI, upper GI, endocrine surgery, and pancreatic surgery. After that, we started to think about the application on abdominal wall surgery. And so we thought about the application on single port TAPP, but at the end of our experience with the single site TAPP, we concluded that there are limitations in unfavorable cost-benefit ratio and on technical conflict of movements. And so it cannot be the treatment of choice for bilateral and recurrent hernias. So we suggested to use only for the TAPP with the classic 3-port robotic approach for the ergonomic advantages for the surgeon. And what about our experience concerning ventral hernia repair with robotic surgery? There is a large range of options in robotic surgery for ventral hernia repair. Concerning the intraperitoneal onlay mesh, the IPOM repair, it can be done with feasibility, reproducing all the steps of laparoscopic repair. So we can close the defect very easily. We can place the mesh and we can fix the mesh, avoiding the use of tacks. So we can use for IPOM repair with the robotic approach the suture instead of the tacks. And this is very, very important also for the postoperative outcomes of the patient in terms of postoperative pain, because we know that avoiding the tacks, maybe this can be very advantageous for the patient. Another option for robotic approach is the preperitoneal repair. This is a flank ventral hernia in an old woman, and we can approach the properitoneal space, making a very easy dissection of the hernia sac, dissecting all the defect and preparing the preperitoneal space. We can close the defect, reducing also the hernia sac, so reducing the postoperative seroma. We measure the flap and we can put a mesh a self-adhesing mesh that can be easily placed in the preperitoneal space. Of course, at the end of the procedure, we close the defect, and it's very important also to close all the defects of the peritoneum. Another option is the reproducing of the rivstoppa repair for ventral hernias, in this case for rectum diastasis with umbilical hernia. We start cutting the posterior sheet, starting from the left rectum muscle. We dissect the premuscular space, and we perform the crossover on the other side, on the right rectus muscle. We reduce the content and the hernia sac of the umbilical hernia, and we complete from the xiphoid to the pubis all the dissection of the retromuscular space. This is the aspect at the end of the preparation. And now we reconstruct the linea alba, closing the defects and reconstructing the anterior rectus sheath with a barbed suture. This is the final aspect. We measure the space that we have created to put a mesh. Now we can close the posterior fascia, and we use, in this case, a biosynthetic mesh that is very easily to place inside. We don't use fixation, but only fiber and glue. The mesh is well adherent to the wall. The final step of the procedure is to close the posterior sheath with a barbed suture. This is another option that is a transversus abdominis release performed, fully robotic performed with the posterior component separation. We start to dissect the medial edge of the right rectum muscle. As you can see, we are dividing in two parts the hernia sac, and then we reach the posterior rectus muscle. We completed the dissection, preserving the neuromuscular bundles. When the dissection of the right part of the rectum muscles is completed, we start with the TAR, starting from the arcuate line. Here is very easily, we can see the transversus muscle, and we complete the dissection of all the right side. Now we measure the right side of the flap, and then we put a mesh that is a rolled mesh with a stitch on the half of the mesh. We can fix the mesh only on the right side. We inserted the trocar on the contralateral side, and now we start to dissect the left side of the posterior component separation. So we can complete also the left side with transversus abdominis release. It's very important to reconstruct the posterior sheath. Then we insert the suture to perform the suturing of the linea alba into the anterior aspect. Once the anterior fascia is closed, we start to close also the posterior sheath. And so once all the preperitoneal space is completed, we enroll the mesh and we complete the fixation of the mesh also on the left side. Fibrin glue is sprayed on the mesh and the drain is put in the retromuscular space. The surgical treatment of an incisional hernia is not to simply close a hole, but the abdominal wall reconstruction. So this can be easily performed with a robotic approach. Our experience in our last 3 years include 162 patients. We have performed almost 60% of our procedure for benign procedure, and more of the half of that are for hernia surgeries. And 48% are for incisional hernias. In our experience, the robotic repair is associated with satisfactory outcomes and short length of hospital stay. We have had only 11% of recurrences in Taurup repair, and those are our outcomes. This is my recent personal algorithm for ventral and incisional hernia. We reserve a laparoscopic approach for small defects, especially in obese patients, with the preserved good tension of the abdominal wall. And if the patient has an hernia with rectus diastasis until 7-8 centimeters, with the possibility of restoring the midline without tension, we perform an open rib stop-bar repair or a robotic Taurup. For greater defects with complex abdomen, loss of domain, lateral hernia, lumbar hernia, subcostal, and parastomal hernia, we perform a component separation technique, posterior component separation technique, or a robotic TAR. Thank you for your attention.
Thank you, Diego, for this very nice presentation from Napoli. Last but not least, we have one more speaker from Italy, Professor Bianchi from the Ospedale San Paolo in Milan, Italy, and René share with us what he will talk about today.
His talk will be also about robotic surgery, minimal invasive abdominal wall reconstruction, robotic approach, and new prosthetic materials.
Excited to see the last presentation. Let's go.
Thank you for a kind invitation at the International Hernia Symposium. Today I will talk about the robotic approach to minimal invasive abdominal wall reconstruction. Just a few introduction about the background. We have available two techniques, an open technique and laparoscopic technique, with advantages and some drawbacks. The open repair, the standard repair rib stop-bar technique, is a technique with a myofascial release, offset tension as advantages, is a cost-effective mesh and fixation operation, and mesh is placed in a protected space. The minimal invasive approach is an approach with low wound morbidity, low mesh infection, less pain, but we have some drawbacks about the position of the mesh that is an intraperitoneal mesh. We have some study about the laparoscopic and the open surgery technique, and laparoscopic technique is a technique with lower risk of surgical site infection, 3% versus 13% of open repair, and with a shorter hospital stay. So the advantages, the well-known advantages of minimal invasive surgery, and even the guidelines of the European Association of Endoscopic Surgery and European Hernia Society say that laparoscopic procedure is a safe and effective procedure, can be done in obese patient. The intraperitoneal mesh placed intraperitoneally is safe. We have to obtain a 3 to 5 centimeter overlap of the defect. But as I told before, there are some drawbacks, and in many papers we can see that we can have a recurrence rate up to 30%. We can have bulging, seromas, pain, and also erosion and adhesion of the mesh in contact with the bowel and with the abdominal organs. So how can we overcome this limitation? So why we need something different? We need something probably helpful to close the primary defect, some alternative to the tax, and particularly we need to have something, a technique with the position of the mesh, not in intraperitoneally, but extraperitoneally. So this is the reason, because we thought to the robotic technique, so to put together the advantages of the both technique, the open and the laparoscopic technique. In this case, I think that robotic can be helpful to us, because the potential advantages of the robotic platform are the dissection, that is an easy and precise dissection, even to perform the adhesiolysis, the enterolysis. It's possible to obtain a good space and a good retromuscular flap. The intracorporeal suturing is a great advantage of robotic technique, and so it's possible to close the primary defect and even to close and to fix the mesh without the use of tacks, and then to obtain the position of the mesh in an extraperitoneal or retromuscular space. So we can modify, we can adapt a complex procedure to from open to minimal invasive surgery. We have few data available about robotic technique. It's still a technique with not a large diffusion, and so we do not have a lot of data available. But with the first report, we can read in literature that after robotic repair, we have a shorter length of stay and low blood loss and low complication and readmission rate, even compared to open or laparoscopic technique. I want to show you the docking of the robot with the different effect of the abdominal wall. We can have an upper docking for the suprapubic or lower midline defect, as in this case, pre-Toka technique with the camera in the middle and the two right and left arm in an up position. A bottom docking for the defect of the midline, subxiphoidal or upper midline defect, as you can see in this picture. And this is the picture of the robotic trocar, 8mm trocar with an assistant trocar to insert the needle and to insert some larger instrument. And this is an external view of the robotic system docked with the bottom to up. Then we have a side docking for midline defect, not too large or lateral defect. And so a side docking, in this case, a left side docking for the right defect, or a bilateral side docking when we have to perform a bilateral TAR procedure for the large midline defect, as we can move from a left side docking to a right side docking, or alternatively. As you can see here, this is a left-right box, and then we move our robotic system, that is an XI system of the Da Vinci robot. It has a boom, and it's possible to move quickly and fast from right side to left side to perform a bilateral TAR procedure. This is the right side box. This is our experience. We started with the robotic technique for abdominal wall repair or incisional and inguinal hernia repair from January 2007 until December 2020. This is our patient, under 91 patient, and in 136 patients we repaired a ventral hernia. We started with inguinal hernia as a learning curve period, and now we are performing inguinal hernia repair just for training for young surgeon. And you can see the baseline characteristics of the patient, 113 male, 78 female with this age and with this score. 35% were incisional hernia, 36% umbilical or epigastric hernia, and in less than 30% an inguinal hernia repair. And the mean the defect was 4.4 centimeter as range. During the time, we reduced, of course, the inguinal hernia, as at the beginning in 2017 were 36 patients, and we increased the number of umbilical and incisional hernia repair, decreasing the number of inguinal hernia repair treated robotically. So we performed several procedures, and now we focused mainly on ribs plus or without TAR, the release with bilateral docking, or the TAROP, so the umbilical repair and retrorectal repair with crossover with a lateral or a bottom to upper or upper docking. These are in the last period the incisional hernia that usually we repair robotically. I'll show you a short 2 minutes video just to show you a bilateral TAR with the midline defect and the right subcostal defect. This is the left. I show you just the left side approach to show you the component separation and the release. You can see the large midline defect and how we can reach the retrorectal space, and you can see below the transverse abdominis, and you can appreciate, of course, stability, the characteristics of the robotic system, so stability of the vision, the possibility to move the instruments with a wristing movement. This is the release of the transversus abdominis, and you see that we use the monopolar scissor in the right hand and a bipolar forceps in the so-called left hand. We are in the upside now. You see the subxiphoid and the midline and the transversus abdominis released, and we go below until the diaphragm. And this is one of the most difficult defects. You see the transversus abdominis released and the diaphragm below, and we can create a space below the diaphragm in order to place a large mesh to completely repair the defects. The great advantage of the technique is that we can go, now we are below at the level of the arcuate line, and so we are doing a bottom to upper separation. And the advantage I was telling is the possibility to follow exactly the plane with a good exposure, a wide exposure of the retromuscular. You see the epigastric vessels, the iliac spine, and we reach also the inguinal hernia region from up to bottom and completely laterally in order to create a wide space following the plane. Here we have, of course, the defect of the peritoneum and the posterior fascia at the level of the midline defect. And then we put together the two planes of the release, of the transversus abdominal release, the upper plane that we saw before at the level of the diaphragm, and the lower plane that you see before at the level of the arcuate line and below the defect. So you see the subcostal and subxiphoid defect in the upper part of the screen, and we use the left hand grasper in order to put together the two plane that we have created retromuscularly. So the right TAR has been completed, and the instruments are placed on the left side, and you see the defect is closed. And you can see with the barbed suture, we close the defect. It's easy with the robotic system to suture intracorporally and to close the defect. At this point, we move from the contralateral TAR. I don't show you the images of the contralateral TAR, is exactly the same. Now we are closing the posterior fascia and the peritoneum, again with the running suture, with the barbed suture. You see the running barbed suture closing the defect. And after the closure, we can place our large mesh after the closure of the direct defect. In this case, we close only the abdominal defect, not the subcostal that is not easy to close, and we have some tension. So again, a barbed suture, closure of the primary defect is easy with a down to up vision of our abdominal wall, and then we place a very large 40 or 50 centimeter long-term absorbable mesh that is fixed with glue and without any tack, or even without any stitches, just with the glue, a very large mesh, low absorbable time, completely absorbable mesh. These are our results, and with the different technique that we have performed, and what we researched, we didn't add any intraoperative complication, and we didn't convert any one of the operation to open or laparoscopic technique. The range and the mean time is of course, they are particularly the TAR bilateral are time-consuming operation, and so you can see that the time is going from 90 minutes to 420 minutes with a mean time of 168 minutes. So a long operation, particularly when you have to perform the operation that you saw in the video. As post-operative outcome, we had two reoperations, one for a bleeding in the retromuscular place and the other for a bowel occlusion after a Costa procedure. And we had to reoperate two patients and just one readmission. So acceptable complication rate. So to conclude, I have to say that the robotic technique for the abdominal wall defect repair is a safe and feasible technique, and the main advantage is the possibility to reproduce exactly the open technique in a minimal invasive fashion. This, I think, is the main advantage of the robotic approach. You can close directly the defect because it's possible to suture easily with the position of the down to up of the camera, and also the helpful movement of the wristing movement of the robotic instrument. You do not have to use any tacks, and glue is enough to fix your mesh, and you can place the mesh in the right, in the extraperitoneal space, not intraperitoneally, in the retromuscular, creating a large space to to put very wide meshes, avoiding adhesion, avoiding intraperitoneal mesh. Thank you so much for your kind attention.
Thank you, Professor Bianchi, for this very interesting talk about robotics. The future is here, I guess, also what we saw from Diego. That was day 2 of the IHS, the International Hernia Symposium. We are on time, more or less, even if we have planned a Q&A of half an hour. But by answering all your questions in the chat by our presenters, I think you got your answers, and that's why we will close the meeting now. Thanks to all the speakers. It was a great afternoon. I think we learned a lot, we shared a lot, and I hand over to René to also make his final conclusion of this second day of